contraception and safe abortion services. So we are still having a good memories of last tenure of Lakshmi Madam, and I can see her that when she has given me opportunity to organize Chai Pe Charcha every month, and we have done covered lots of topics with all of you. So now again, thanks to Dr. Parul Kotetwala, Dr. Jaideep Tank and all team that they have given this opportunity to being a convener of this webinar with Dr. Shobha Gudi and Dr. Ranja Khanna. So today I am so happy that I have all ICOG teams, I should say that pillars of ICOG, that as a chief guest, Dr. Uday Thanewala sir, Dr. Lakshmi Shrikhande, guest of honor, and Dr. Parag Beniwale. So first of all, I am grateful to Dr. Jaideep Tank sir, and I invite Dr. Parul Kotetwala, ICOG chairperson, to address and say a few words and welcome our guests. Dr. Parul sir. I'm not able to see Dr. Parul. Then I invite Dr. Sarita Bhalerao, Secretary of ICOG. I have called them. I sent message. Probably I'm not able to see them. So
Dr. Uday is here.
So yeah, so Dr. Uday is the Vice President of ICOG, chairperson elect.
Hey, he's a past chairperson of ICOG.
He is the chairperson elect ICOG.
Past vice president, he has already been.
Dr. Sheila Mane is there, madam. Are you there?
Uday, so now you are chair elect.
Uday is already been the chairperson. Bharti
वो पराग को refer कर रही है. Actually, she is referring to Parag.
वो लक्ष्मी के पहले Uday was the chairperson.
Please just give you introductory words and start the session. Yes, Parag sir.
Okay, good evening. I bring greetings from ICOG, and it's indeed a pleasure to be sitting here with very dear friends who've put in a lot of work for Proxy ICOG all these years. Thank you all for joining. And I must appreciate efforts put in by our governing council members, Dr. Shobha Gudi, Dr. Bharati Maheshwari, and Dr. Ranjana Khanna in putting into this webinar on family planning, contraception, and safe abortion services. The topics today are pretty pertinent, where we talk about abortions in the first and second trimester, and to address us, we have Dr. Nozer Sheriar, who will enlighten us on this subject. So once again, welcome all of you, and thank you, Bharti, for having me on this program.
Thank you, sir. And I now, we are happy that we have a chief guest, none other than Dr. Uday Thanewala, sir. And we all know that he's a consultant obstetrician at Navi Mumbai and a chairperson ICOG 2122, Vice President Foxy, Treasurer PCOS Society of India, and had lots of credit and academic credits and publications. So, sir, now over to you for your own ICOG as a chief guest in Safe Abortion webinar series.
Thank you so much, Bharti, for having me here and for this very interesting program, because it is so well thought of, and the people you have chosen, right from Dr. Jaideep Tang, who has done so much of work on abortions, right till Dr. Nozer, they both have been working on abortions. They are the ones who have been instrumental in even liaising with the government, to get the rules changed, to get the rules streamlined, to make it more favorable for the obstetricians, and they have been spreading the awareness of abortions. And I'm so happy you're having here, because recently the abortion law has changed. It has increased from 20 weeks to 24 weeks. The methods have been very different from what it was when we were undergraduates. We have got so many other new drugs, etc., which help us and make the abortion, second trimester abortion, easier. We have got the first trimester abortion, which now we can do safely with an ultrasound control, because all these things have come up so well. And you have chosen all the speakers so well. The topics are so well chosen. The first trimester, second trimester, and the panel discussion. Of course, Nozer is there as the speaker to round up the whole thing. So congratulations for arranging this particular webinar. And I believe all those who will join will hugely benefit for him. My greetings to everybody from ICOG who is here, Parag, Lakshmi, and all the other people who have joined. And very nice work, Bharti. Do keep it up. And of course, greetings to Shobha and Ranjana Khanna. Please carry on, and it'll be very interesting to listen to this seminar. Thank you.
Thank you, sir. So thank you, Dr. Uday Thanewala, sir. And now I invite our guest of honor, past ICOG chairperson, Dr. Lakshmi Shri Khande Madam, to say a few words.
Hello. Very good evening, everyone. I'm so happy to be here now as guest of honor for this ICOG contraception and abortion and family planning web series. And when I was chairperson last year, we used to have a dedicated web series every month on this topic, and every time we used to have different topics and attendance was very high. And when we had the 3-day certificate course and Richa was the convener, we had 1800 registrations for that MTP Act and the abortion techniques. I'm so happy that Ranjana, Shobha and Bharti, you are having a dedicated webinar today on first trimester, second trimester abortion, then panel discussion on difficult cases, and who else than Nozer to speak on the recent MTP amendments? Because I know Nozer, Jaideep, and Basab, these three men are so passionate about the MTP Act and the family planning services. So very happy, and speakers are fantastic. Your topic is fantastic, and I'm so happy that ICOG under the chairmanship of Dr. Parul Kotadawala, then Secretary Dr. Sarita, Vice Chair Dr. Sheila. You are doing a fantastic job, and keep it up, and all the very best for this web series and today's webinar as well. Thank you for having me here.
Thank you. And your all presence really means to us and for our audience also. Thank you very much. And now I invite Dr. Parag Gunewale, sir, as our guest of honor, sir. So
No,
for
no,
this
don't,
session,
don't,
to
Bharti,
say,
don't waste time in that. Let's begin with the session.
okay. And Dr. Secretary Madam is not here. Dr. Madhuri Patel Madam is not here. Madhuri Patel Madam, are you there? Dr. Sheila Mane Madam is not here. So we comes to our session, and I invite on the first session our chairperson, Dr. Ashish Kumar Mukhopadhyay, sir. Sir, are you there? So when he will come, he will join, and we all know that is the chairperson in the today's session, the principal and professor, CCS College of Fox and Gynae, Kolkata, and Vice President Foxy 2016 and 17. And now I invite the other chairperson of this top session, and that none other than Dr. Shobha Goody, Madam. Madam, are you there? I think she also stuck in some emergency. So now invite our first session, and that is our speaker is none other than Dr. Ranjana Khanna. We all know that how active and lively person she is, and is a past Vice President Foxy 2017, Founder President ISOPA Prayagraj, ICOG Governing Council members presently, and President Allahabad Option Gynae Society 13 to 16, and I am remain visionary for her lots of academic organization conferences what she is doing academic activity, and has achieved lots of national awards. And now to Dr. Ranjana Khanna Madam, without doing any delay, to your topic, that is the abortion in the first trimester, the clinical aspects. And today we are fortunate that we will have Noja Sheriar sir also at 5:30 p.m. So we will cover clinically Dr. Ranjana Khanna Madam's first trimester abortion, then second trimester abortion by Dr. Richard Sharma, already MTP committee chairperson, followed by a very crisp panel on the documentation issues, and then talk by Dr. Noja Sheriar sir. So Dr. Ranjana Khanna.
Thank you so much, Bharti, for this lovely introduction.
Yeah, इसको full screen, ma'am. You can do it full screen.
I'll go back to the original, the beginning.
Yes.
Okay. Just a minute. Okay. Now it's visible, my screen?
Yes, Ranjana, we can see.
Okay, okay. A very good evening. Today I'll be speaking on clinical methods of abortion in the first trimester of pregnancy. First trimester, that is up to around 13 weeks of gestation. Methods of termination of pregnancy are medical methods and the surgical methods. Surgical methods would be manual vacuum aspiration, suction evacuation, dilatation and evacuation, dilatation and curettage, and the medical methods are mifepristone alone, misoprostol alone, mifepristone and misoprostol, which is the most effective and most commonly used method, methotrexate and misoprostol. Now we come to the surgical methods, MVA. Manual vacuum aspiration is an aseptic procedure that involves the evacuation of the uterine contents by the use of a handheld plastic aspirator. It is used commonly in both developed as well as in developing countries. Performed up to 7 menstrual weeks without cervical dilatation, but can be performed up to 10 weeks comfortably. Can be done in the OPD, done by flexible vacuum cannula 6 to 12 mm and a 50 ml plastic modified syringe. Vacuum of up to 600 millimeters of mercury is created, does not need any suction machine or electricity. Hence is ideal in rural settings in India. Advantages: the WHO recommends MVA for uterine evacuation because it is safe, high quality, affordable, easy to learn, easy to use, small, portable, quiet, no electricity required, ideal for performing the procedures in OPD. Advantages of this manual vacuum aspiration over other techniques of termination of pregnancy are less pain, so less need for analgesia, reduced risk of complications, that is bleeding, less post-abortal morbidity, less hospital stay, less time taken, that is about 10 to 15 minutes. Now, what are the steps for performing manual vacuum aspiration? First of all, we have to prepare the patient, administer pain medication before the procedure to have maximum effect when the procedure begins, give prophylactic antibiotics, ask the patient to empty her bladder, conduct a bimanual examination to confirm the uterine size and the position. It is a very, very important part of the procedure. Insert the speculum, observe for signs of infection, bleeding, or incomplete abortion. Then perform cervical antiseptic preparation. Use an antiseptic soaked sponge to clean the cervical os. Start at the os, spiral outwards without retracing the areas. Repeat until the os has been completely covered by the antiseptic. Then you perform the paracervical block, which is very essential. It is required prior to performing the MVA, use of MVA. Perform paracervical block with 20 cc of 1% lidocaine or 10 cc of 2% lidocaine. Inject a very small amount of lidocaine, 1 to 2 cc, into the cervix at the tenaculum site where you are going to catch it with the valsalum or the Ellis forceps. Then inject the remaining lidocaine in equal amounts at the cervicovaginal junction at 2, 4, 8, and 10 o'clock. Always aspirate before injecting to prevent intravascular injection of lidocaine, which can lead to high reactions. Now dilate the cervix. Observe the no-touch technique when dilating the cervix and during aspiration. We must be very careful about the hygiene. Now we will dilate the cervix, either use mechanical dilators or progressively larger cannulas to gently dilate the cervix to the correct size. Now we insert the cannula. Apply traction to the tenaculum, insert the cannula through the cervix, pass the os into the uterine cavity. Never be very forceful when you are inserting the cannula. Now prepare the aspirator. Position the plunger all the way inside the cylinder, push the valve buttons down, forward until they lock, pull the plunger back until the arms snap outwards, catch on the cylinder base. Now we will attach this prepared aspirator to the cannula, the Carman's cannula. Release the vacuum by pressing both the buttons. Evacuate the contents of the uterus by gently and slowly rotating the cannula 180 degrees in each direction using an in and out motion. When the procedure is finished, you can pull out the whole thing, or you may depress the buttons first and disconnect and then take it out. Now you inspect the tissue. Be sure that the products of conception have come out. And then we can perform, when you are sure about this, that this is a complete abortion by seeing with an ultrasound, then you can perform any concurrent procedures like putting in an IUCD. And then we can shift the patient. So there is another surgical method, suction evacuation. procedure of choice for medical termination of pregnancy up to 12 weeks and for abortions. And normally the patient comes as inevitable abortion, then the os will be open in that time. Indications would be an induced abortion, MTP up to 12 weeks, incomplete abortion, inevitable abortion, missed abortion, molar pregnancy. Prior to the procedure, the cervical dilatation is done by either the slow methods, that is 400 micrograms of misoprostol per vaginally, or we can also insert the laminaria tent. But nowadays it is misoprostol which is being used mostly, or the rapid method, serial dilatation using the Hegar's dilator. Suction pressure is kept at about 500 mm of mercury. Now, what are the complications? Early complications could be heavy bleeding. Cervical injury could be there, especially when you're trying to force the cervix open with the Hegar's dilator because they're metallic. Uterine perforation could be there. And late complications could be PID, secondary infertility, cervical insufficiency, uterine synecdoche formation. Now, dilatation and evacuation. It involves dilating the cervix and evacuating the fetal products from the uterus. It is done as a one-stage or a two-stage procedure. One-stage procedure, cervical dilatation and uterine evacuation using the suction and the ovum forceps. And this is all done simultaneously. First, you can use the suction, then you can use the ovum forceps, and you can also do a check curettage by a blunt forceps or a flushing curette. So, done in incomplete abortion, inevitable abortion, missed abortion, molar pregnancy with favorable cervix, or in the process of expulsion, induced abortion in the first trimester. Now, one thing which I wanted to stress on was that it is extremely important to know the direction of the uterus. So, bimanual examination must never be overruled. And when you are sure of the direction, because sometimes what happens if the uterus is very much retroverted, and then you put in the metal dilator, the Hegar's dilator, and God forbid, if you're putting it in the wrong direction, then it can easily cause a perforation of the uterus. There was this one case when I was a demonstrator in GSVM. Then this house surgeon, she dilated. She did not realize that it was a retroverted uterus. The uterus got perforated, then she put in the ovum forceps and she pulled out the mesentery, and after that she pulled out the bowel. Then she got suspicious. She called out to me. She said, ma'am, just see what's happened. So when I came, I said, oh my God, this is the bowel you've taken out. So immediately the patient had collapsed by then. We rushed her to the OT, but thank God we managed to save her. So remember one thing, that be very careful, because I feel that savdhani hati to durghatna ghati. We have to be extremely careful about the position of the uterus since it's a blind procedure. So two-stage procedure is when the cervical preparation is first done. Tablet misoprostol 400 micrograms vaginally or sublingually before the procedure. Evacuation is done at least after 6 hours so that the cervix is completely dilated. It is done in medical termination of pregnancy up to 20 weeks, molar pregnancy with a tightly closed cervix. Now, complications of DNE. Early complications, same. You can have excessive bleeding, cervical tear, uterine perforation, inadvertent injury to the pelvic vessels, intestine, and the bladder, shock due to excessive hemorrhage. Intermediate complications could be pelvic infections, endometritis, myometritis, perimetritis, and parametritis. Delayed complications could be PID, hematomitra, secondary infertility, Asherman's, cervical insufficiency, or chronic pelvic pain. Dilatation and curettage. It is done in cases of retained products of conception under all aseptic precautions and antibiotic coverage. Suction cannula is not used in this case. Gentle curettage is done and the tissue can be sent for histopathological examination. The indications, procedures, and complications are very similar to D and E. Now coming to the medical methods. Prerequisites, there should be no medical contraindication, good support system in case of need of surgical evacuation or any complication, ability to follow up visits. Patient should be willing for it, and she should be told that if it fails, she may have to resort to a surgical method. Contraindications, absolute contraindications, suspected ectopic pregnancy or undiagnosed adnexal mass. So please be very careful. It is very important, even before a medical method of termination of pregnancy, to get an ultrasound done. Chronic renal failure, chronic adrenal failure, or concurrent steroid therapy, hemoglobin less than 8, that is an anemic patient because she can bleed heavily, uncontrolled seizure disorder, uncontrolled hypertension, cardiac disease and hemorrhagic disorder, and there is a relative contraindication of a heavy smoker. Now, the medical methods. Mifepristone, it was very much used in our times. Mifepristone was the first drug that came into the market in the name of RU486. But nowadays, it is not used alone because of the poor success rates. Mifepristone and misoprostol are the most commonly used. Methotrexate and misoprostol, methotrexate is avoided because of the cytotoxic effects of the methotrexate, but it is effective, and misoprostol alone. We'll come to these one by one. When we talk about the most important method which is being used, we have that 5-pill pack nowadays, mifepristone and misoprostol, which are also popularly known as abortion pills. Mifepristone is a progesterone antagonist and leads to decidual necrosis, increased prostaglandin production and uterine contractions. Misoprostol is prostaglandin E1 analog, softens the cervix, causes strong uterine contractions. Now, what is the success rate? 8 weeks pregnancy or less, 94 to 98% success. 8 to 9 weeks, 94 to 96%. 9 to 10 weeks, 91 to 93%. But if we give extra dose of misoprostol, then the efficacy goes up as high as 99%. So this extra dosage would be 400 micrograms of misoprostol given every 3 hourly, maximum of 5 dosage. And that would really shoot up the efficacy. Then 10 to 11 weeks, otherwise the efficacy is 87, but with extra doses of misoprostol, it goes up to 98%. Now the dose and the regimen. Day 1, tablet mifepristone, 200 milligrams orally on day 1. Day 2, we don't give anything. Day 3, 4 tablets of misoprostol given either per vaginal, sublingually, or buccal. Almost 80% of patients abort within 24 hours of misoprostol administration. The minimum recommended interval between the use of mifepristone and misoprostol is 24 hours. The woman should be called after 15 days for a re-checkup to confirm whether complete abortion has taken place or not, and subsequently after 4 weeks, and contraceptive advice should be given at the same time. So this is very important. And another thing which I wanted to say was misoprostol. Whenever we are prescribing in a patient who is breastfeeding her baby, then we must know that misoprostol gets converted into misoprostoic acid, which can cause diarrhea in the infant. So we should try that the patient takes, before taking misoprostol, she feeds her baby, and after the misoprostol, after 4 hours, she feeds the child. So methotrexate and misoprostol were effective in inducing abortions of 8 weeks gestation. Procedure is a promising alternative to surgical abortion. Methotrexate 50 milligrams before 56 days of gestation, followed by 7 days later, misoprostol 800 micrograms per vaginum is found to be very effective. Misoprostol may need to be repeated after 24 hours. This regimen is less expensive but takes longer time than mifi and miso combination. And plus, there is that slight fear of people that it may be cytotoxic. Now, coming to misoprostol alone, this is actually, and this regimen is coming up in a big way in USA, because though the Drug Federation has approved mifepristone in US, but it is still not available for usage. So their stress is on misoprostol over there. Currently available data suggests that misoprostol as a single agent is a reasonable option for women seeking abortion in the first trimester. This treatment is clearly less effective than the standard regimens that also contain mifepristone, and thus enhanced vigilance should be recommended to detect potential failures. Misoprostol alone may be preferred by some women because easier to obtain, less costly. Further research is needed to refine the regimen, addressing issues such as optimal misoprostol amount per dose, dosing intervals if the drug is administered sublingually or buccally, which may be more convenient for women than the vaginal insertion, and the efficacy of these regimens in the late first trimester. So when we compare the medical and the surgical methods, the advantages would be for the medical methods, avoid surgery and anesthesia, less painful. I don't agree with this. It's often very painful, and easier to do, yes. And surgical methods, quicker, more certain, can be done under GA, so becomes practically painless. Disadvantages, with medical methods, bleeding, cramping, nausea, waiting, uncertainty due to unpredictable success, extra visits to the clinic, and compliance is needed, need of surgical evacuation for failure. Success rate is 95%, and with the surgical methods, it is invasive, small risk of uterine, cervical, and bowel injury or infection, and the success rate is 98%, which is definitely better, but then it is up to the patient. We should give the patient the option of choosing between medical and surgical methods. Pros and cons of both should be clearly explained to the patient, and she should always come for follow-up. And before I end, I'm standing for the post of President Foxy, and I would request all of you for your vote and support. Thank you all so much.
Thank you very much, Dr. Anna Khanna. Such a comprehensive talk and in a very fixed time. So thank you very much, Dr. Shobha. You are here. So
Should
you
I
have
take it forward?
Yes, so Dr. Shobha, I'm not able to see her. So, this is really very important thing that you have covered the MBA, that we need to cover it because all of should be updated in this technique. And MTPC, you have covered all latest updates.
Hello,
So,
Bharti.
yeah, you are
Can
there.
you hear
Shobha
me?
is there.
Say a few words
Yeah, yeah.
for this conclude this.
Can you hear me?
Yes,
Yeah,
we
yeah, we
can.
can hear you.
So wonderful talk by Ranjana madam, and thanks for all the seniors who are here that we were able to do this program. Bharti, you have crafted the program extremely well, and I am very happy to introduce Dr. Richa Sharma for the next talk. Can you please make it slideshow? Because I'm logged in on a mobile and I'm okay. So Dr. Richa Sharma, I invite you to give your talk on second trimester MTP. You are the professor, OBG, University College of Medical Sciences, GTB Hospital, Delhi. You are the current, MTP committee chairperson and national corresponding editor for the journal also, and for Jogi, joint secretary IAG Delhi, and
Thank you, Dr.
AOGT endoscopy committee chairperson. You have won several awards, Richa, and you are a very prolific author, more than 75 publications. It has been very nice working with you as committee chair, and I invite you to deliver your talk on second trimester MTP.
Dr. Richa, please share your slides. So now we have Dr. Richa Sharma. She's again dedicated Foxy and an MTP committee chairperson and doing lots of work. So she's going to deliver her talk on the second trimester abortion.
Second trimester abortion.
Yeah, clinical issues.
Yeah, correct. My volume was very less accidentally. I hope the introduction was heard, Bharti. I'm sorry.
Yeah. Thank you, Shobha madam, for the kind introduction, and thank you, Dr. Bharti Maheshwari and Dr. Ranjana Khanna madam, for giving me the opportunity. And thank you, ICOG. Can I share my screen? Can you allow me to share the screen?
Yes, please, you do.
I'm not getting the
person,
option.
please see whether she can share.
Nilima, please, can you enable sharing for Dr. Richa, please?
I think she should already.
No, I'm not getting the option to share.
So you have login by your name, na?
Yeah,
okay. Yeah, so who is there? Poonam or Nilima, anyone?
Richa, there is an option in the lower part, na, share screen.
That I know, ma'am, but I'm disabled. I'm not getting this thing.
Okay.
Hello, anyone from technical side?
Yeah. Gauri, please check.
ICOG Nikita. Please see, she can share the screen.
Richa, ma'am.
1 second, I'll just see. I'll share my entire screen.
Yes.
Is my
She's
screen
the co-host,
visible?
we can share.
Yes, Richa, you need to open your presentation.
Acha. So, okay, I've shared my entire laptop because I was not getting the access. So, okay. So, I'll share this way. Okay. Is it visible now?
What?
Not yet open.
No, the presentation is not visible, but your
Presentation
screen
is
is
not
visible.
open.
Can
You
see
must
my
open.
slide?
Please click.
No, no.
You open your folder, please, Richa.
Second trimester MTP.
You have selected your folder, double click it.
Is it open in your screen, Richa?
It's open, ma'am. Actually, I don't know कि there is some-
आप एक काम करिए
share कर लो,
आप
Richa.
हाँ yes you stop
पहले खोलो
sharing,
फिर share करो यार.
keep your presentation open and then share it. Yes.
So till Dr. Richa is opening, so we all can know that the nowadays the most important issues what we want to discuss. As MTP, it is the basic thing what we learn during our post graduation during MBBS. We lots of study about that and learn, but it's still it is the subject where we have to learn and we have to update because of MTP Act, because of lots of social issues, because MTP is not only medical things, it covers lots of social, lots of legal things. So we have to remain updated, and it is time that we obstetricians can't deny for MTP. We should not escape to do MTP. We should do because unsafe abortion, otherwise women will go for the unsafe abortion, and that will lead to lots of maternal morbidity and mortality. Yes, Richa ka slide आया.
Can you see the slide now? I don't know
अभी तो
why
नहीं
what
आया.
is happening this time. Na this just I will just log out.
मैम आप एक काम करिए.
नहीं I know the
No
thing,
ma'am,
but I just log out once and I will start it. Just give me 2 minutes and apology.
मैंने तो share screen बता दिया. Should we start with the panel first?
वेट तो करो, तुम्हारा साउंड नहीं है.
Risha,
नहीं है.
भारती आपके पैनलिस्ट है इधर?
भारती पैनलिस्ट है तो पैनल स्टार्ट कर देते हैं ना.
पूछ लेते हैं रिचा का 2-3 मिनट में आ रही है, वरना हम पैनल, हाँ टाइम वेस्ट नहीं है हमारे पास.
हाँ पहले पैनल कर लो ना,
बाउंडेड टाइम है.
बात तो वही है.
यस, तो हम पैनल स्टार्ट कर दें क्या? पैनलिस्ट तो है मेरे मित्रा मैडम बैठी दिख रही है मुझे. अभी मीना मैडम भी थी. तो
शोभा, आर यू गोइंग अहेड विद इंट्रोड्यूसिंग भारती और शुड आई डू इट?
नहीं, रिचा वैसे करती तो बहुत रहती है, उसको प्रॉब्लम आना तो नहीं चाहिए. या तो वो मुझे मेल कर दें. तीसरे चौथे पैनलिस्ट मेरे डॉक्टर ज्योति बांग्लो, ईशी, और चौथी
स्नेहा इज देयर,
मीना सामंत मैडम आ गया. चलो रिचा है. पता नहीं इसका क्या प्रॉब्लम है.
I think Richa should give it to Nilima or someone, na, to play it. Bharti, you are muted.
Richa, if you mail me, then I will share. आ गया, खुल गया रिचा. रिचा इट्स ओके.
खुल गया.
रिचा इट्स ओके, बस प्लीज लिमिट थोड़ा फास्ट करना होगा बिकॉज 5:40 पे हमें डॉक्टर नोदर को देना होगा.
So apologies for this inconvenience.
कोई बात नहीं.
Quickly, I will go to my topic now without wasting much time. So I'll be talking about MTP in second trimester, and I bring greetings from UCMS and GTB Hospital, Delhi. So now why MTP is such a complicated thing, as we say, because it is medico-legally important, and also it is important from the point of view of safety of the patient in terms of mental and physical health. Why? Because it is governed by the act. So we have to protect the pregnant woman, her reproductive rights, and as well as we have the obligation to protect the life, and therefore we have to provide for the protection of the fetus also. So this is why the MTP Act was devised, and Dr. Nojar Sherian sir will be taking in detail MTP Act, so I'm not going into that detail, but I would like to tell that new MTP amendment, it was implemented on 24th September 2021, and it was notified on 12th October 2021. So MTP Act, it tells us clearly the person who should do the MTP, then the indications, place, and paperwork, because these are the four most important components of MTP Act. Now, talking strictly about the second trimester MTP, who can do the MTP for second trimester? So a registered medical practitioner who has a degree, medical qualification, which is defined in the India Medical Council Act. It is a recognized degree.
Your
And also,
slides are not moving, Richa.
hello, am I audible?
You are audible, but your slide is not moving.
Okay, so I think I give up now. Can we start the panel and let me reorient myself then?
नहीं तो ये अभी you were speaking from your slides. They were changing in your laptop.
Next slide नहीं दिखा.
नहीं slide.
खाली front slide open है बस तुम्हारा first वाला.
वो भी full नहीं.
I don't know what is happening.
वो भी full नहीं है क्योंकि top panel नहीं दिख रहा. Top panel क्यों दिख रहा है?
So
full slide नहीं है.
Bharti madam, I'll stop sharing and can you start the panel and I'll just correct all these things and rejoin.
Okay, you stop sharing. Then what you want? We should do panel first, or you are trying again?
Okay, I'll just give one more try and then.
हाँ एक try और लो. पूरा बंद करके उसको खोल के उसको share करो.
Not getting the option to share. Ma'am, can you proceed with the next program? I will just.
Okay, I am just starting panel till that you set your things.
Okay, I'll
और तुम मुझे
introduce
mail भी
you.
कर दो. अगर अब नहीं होगा, then I will run your slides. Okay? Till that, you mail me also.
I don't think Shobha is here, so I'll continue with this panel. Okay. So first of all, we have this panel on difficult situations, and we have Dr. Bharti Maheshwari who's moderating the panel. So Bharti,
Yeah.
your CV?
So yes, I am here with the panel. So as you all know that today we are having a very crisp panel, and that we have a four panelists here with us, none other than Dr. Meena Samant, Dr. Sneha Bua, Dr. Mitra Saxena, and Dr. Jyoti Banglowala. They don't need actually an introduction. We all know Dr. Meena Samant. She was a past Foxy committee chairperson as well as ISOPAP secretary. Dr. Sneha Bua, she was also past Foxy committee chairperson and very active Foxy. Dr. Mitra Saxena, she is still Foxy committee chairperson, and Dr. Jyoti Banglowala, we all know that she is also a medical legal committee chairperson. So we all know that about MTP, lots of work has been already done by past MTP committee chairperson as well as President Foxy. ICOGs, lots of literature is there on the Foxy website, ICOG website, Foxy Focus, and lots of bulletins, and as well as MTP Foxy Focus covering all aspects of abortion scenarios and all clinical aspects, legal aspects you can have on the Foxy website. So I just start this panel with the message of WHO that how we have to prevent unsafe abortion through comprehensive sexuality education, access to affordable contraception, and safe abortion care. And we are focusing on these issues so that we can, we all know that nearly 15.6 million pregnancies are terminated every year in India, and every day 10 women in India die as a result of abortion related causes. So this is enough to justify that discussion should be there, that why we are not still able to restrict the MTP related morbidity. So What are I comes to my panelists, that Dr. Mitra, Dr. Meena, and Dr. Sneha, that what are the important challenges for doing MTP in current scenario? Three
So,
challenges each one of us. What do you think that is the biggest thing we have to address? Yes, Dr. Mitra.
so very good evening, Dr. Bharti. Congratulations for having this very wonderful session. And we all know that in our country, it's very diverse. Whether it is the person who's taking a facility or the person who's giving the services, there are lots of different scenarios and they are all in themselves challenges. So firstly, from the patient side, not every patient in our country actually still knows that MTPs are no longer illegal. So this knowledge is not throughout the country. And of course, there is a lot of difference between the urban and the rural population. Even they don't know that it's not important that a girl can be unmarried of legal age and she can still avail termination of pregnancy. So this is one very, very important challenges.
Dr. Meena, according to you, what are the biggest challenges for you? What is the important issues has to be addressed?
I think which is just saying current, something recent that has happened these days is the extended period of determination that we can have that is beyond 24 and the need for having a board. So at many places this may not be available. It is found in the medical colleges and players. They may not be aware of this. And about even here, only I think last year, much later when the boarding was there and the act, much later it was assigned to the medical college to form.
I'm not very clearly, could not hear you, Dr. Meena. Can I just add from my side that after the patients who are availing this opportunity, even amongst the doctors, there are a lot of gray areas. What is the exact age? What to do if a patient is not of age? How to deal if it is first trimester or
Dr.
second
Sneha,
trimester?
you, according to you, what are the important challenges?
Yes, most
Common भी हो सकते हैं वो.
most important is the social one. Even today, people are not aware that legalization as well as liberalization of the medical termination of pregnancy has happened. So that is one. Also, the secondary status which is given to the woman, not even making able of the decision to go ahead with termination. She wants to go for termination. The family doesn't want, so she lands up into unsafe abortion. That is one. Then secondly, you have the economic aspects. Even the charges which may be so high in the private facilities and the 24-hour government facilities for the termination of pregnancies, they are not available. The access, the physical access, so social factors, the economic factors, also the physical access in the remote places. You may not be having the centers available, or maybe even the qualified staff, the service providers may not be available. So definitely you have all these factors. So challenges are, I think Dr. Bharti, you are muted. You are muted. Please unmute. Dr. Bharti, you are muted. Yeah.
Yes, actually we have to discuss other issues also, so we have to remain on each issues crispy. So as we all know that you all said that the awareness about the public as well as doctors, and important thing that you have said that MTP Act amendment as well as availability of MTP pill without prescription, unsafe abortion, complications during PCPNDT, POXO, MTP in scarred uterus, unmarried girls, social issues. So these are the very important things what we have to address, and we still know that about 80% public, they don't know about the legality of the abortion. And these are the important 3 books that we have to go through: Comprehensive Abortion Care 20218 by Government of India, as well as ensuring access to safe abortion and addressing gender bias sex selection. So this was about, and now Dr. Jyoti, she is, I think, has joined. Dr. Jyoti का कह रही थी, she's okay. So till that, anyone want to take this question that what is the important issues related to MTP Act 2021 that should be implemented in clinical practice? What are the highlights of important MTP Act amendment? Dr. Nozer will tell about this talk, so we will keep related only limited for this. Dr. Jyoti has joined.
Yeah.
Yes, Dr. Jyoti, take your question. Unmute करें अपने को.
Acha, has she joined?
Please unmute yourself. Unmute. अभी unmute नहीं हुआ Dr. Jyoti. You have to click. Organizer, please allow
Yes,
her to.
yes,
The
yes, yes,
Yeah.
thank you.
host should
Thank you.
Now you are audible. Yeah.
Thank you, madam. Actually, that time host was not allowing. Yes.
Yeah. I understand. So, Dr. Jyoti, what is important issues related to MTP Act amendment or whatever MTP Act existing, what we should implement in our clinical practice? How we should utilize this act in our clinical practice?
Actually, we should utilize this act because this particular act amendment just was for the most of the time this unmarried. Due to the social taboo, most of the unmarried girl who are adult also, they are not coming to the gynecologist. They are going to the quacks. So we have to actually spread a word that a girl who is 18 year above can go for MTP if there is a contraceptive failure, because still there are some misconception that unmarried girls cannot go to the doctor for MTP. First thing is that there is many things. So previously there are only two doctors are allowed up to 20 weeks, and then now this is only one doctor. So we have to spread word amongst our patient that if there is some contraceptive failure, that if there is a change of marital status, if there is some mental or some physical issue, they can happily go to their doctor. I just want to say, and
Can I add something?
Yes,
the first and the foremost thing is that all those who are qualified OB-GYN, they should get themselves registered so that they can safely do it. You know, the eligibility and the sanctioning of our centers to conduct these MTP, conduct the procedure itself is the first thing which a doctor should fulfill so that they can cover everything. And depending upon your
So,
practice and your
yes,
available
Dr. Sneha, we will come to every point. So, like MTP Act amendment, because we all are remain little bit apprehensive that we don't know about the facts, we don't know about the how we will maintain the documents, and in fact, we escaped to do MTP. Actually, the situation is that. So, the thing is that MTP Act amendment 2021, we all know it is a view to increase upper gestational limit for termination of pregnancy under certain conditions through sets and access to comprehensive abortion care. And in MTP Act amendment, what important issues we should know that about the forms and about the, yeah, I will tell you in the documentation, as well as it is helpful to know about the selection of case. See what are the indications we can do MTP, what is the gestation limit, and as you said that provider eligibility, we should check it whether place is eligible or not, how we are maintaining the documentation, and of course we should know that what is the violation of MTP Act. So Dr. Sneha, what should be approach for if one is ladies come to you and then she says that she has a 2-month pregnancy and she wants termination, doctor. So what should be ideally step by steps that we should ask and we should see? Yeah.
First and foremost, we have to see whether it is the safety of the patient. So we need to go for the basic investigations. We have to explain what are the options available for ways of termination, whether it is medical or surgical. We have to explain the pros and cons to the patient, and we have to give her an informed choice for her decision. It should not be an enforcement of your one particular procedure. There should be not even the enforcement of the, the contraception following this. You have to explain what is the procedure, what are the complications or, likely to happen during the procedure itself. So counseling plays a very important role. And then of course your formalities, once she decides that what method she wants to go, then accordingly you have to do the formalities, the various the consent forms, you have to go accordingly. You must take the woman's signature. That is most important, and not the husband's or anybody else's in the family.
So very true, Dr. Sneha, and this is very beautifully explained in the website of UP State National Health Mission website, that they have this chart as some woman comes for the termination. First, you do confirmation of pregnancy, then calculate the gestational age, then identify indication of MTP. That is very important, whether she is eligible to do or not. Then discussion on method of MTP, medical, surgical, then provide counseling for contraception. Never forget, and then obtain informed consent of women and the form C. Don't forget, and if you want to take some extra consent, you can take an extra. Then complete the form 1 and provide MTP services, then Form C and Form 1 should be placed in a sealed envelope. Secret and serial number should be written on the envelope. Complete Form 3 admission register. All form to be kept in custody of head or owner of institute and should not be open for routine inspection. Only the CMO has authority to inspect these confidential documents. Strict confidentially has to be maintained. This is again highlighted in the MTP Act amendment. Form 2 is to be submitted to the CMO office every month, and even in case of medical abortions, all the above form has to be filled, all records to be preserved till a period of 5 years. In the admission register, the serial number of MTP in that hospital, clinic or each year will restart from serial number 1 every calendar year. So this is a very important, and you can
Now
see
the
this is
16 column register is to be filled.
this is the website's screenshot I have taken, and you can see that approval of private clinic for comprehensive abortion care services. All forms are available on the website, Form A, Form 2, that we will discuss, and we all
one
should be
thing
aware
more,
of
Dr.
termination of
Bharti,
pregnancy.
one thing more that has come into practice now, which we received, is that they've sent a format in which our MTP register is formatted, that along with the MTP pill. I mean, like, we have to even maintain the batch number, get the date of manufacturing, expiry, and the total number of the kits, MTP kits. That also we have to
good
maintain
thing
in
if
the
it
MTP
happens.
register. This
That
is the
is good thing.
directive by our CMO.
But
So I thought maybe this is something
yes,
new,
yes.
not in the law, but then how they,
So selection of MTP case according to legal eligibility, rule out or high risk factor, check facility at your place, check your eligibility, then selection of method, counseling of women, and don't forget for the counseling for the abortion, but never refuse if she doesn't accept any contraception, and wait for opportunity to counsel her after the procedure. Call her for follow up in a week time and counsel her again. But do not refuse MTP if she is not accepting contraception, but you counsel her again and again, and whenever you can give at the second day of medical methods, or as completion of surgical evacuation is done, you can do contraception. So this was or you have to check the all these anemia and other suspected ectopic adenocarcinoma, hypertension and other cardiac disease, renal disease, and anticoagulant therapy, whether she is not uncontrolled seizure disorder, allergic or intolerant to mefi, meso, etc. This checklist is given in this comprehensive abortion care 2018. You can have this with your staff, and ideally all things should be done so that to anticipate the high risk thing, and you can manage accordingly. Now Dr. Jyoti, what are the important, because this is the most important issue everyone wants to know very clearly, what are the mandatory documentations for doing MTP, what is Form B which should be displayed on clinic, and how it should be get. Yes.
Actually, our hospital and ourselves also, we have to be registered under the MTP Act in our particular CHMO office, and all the private sites in the public sector, or even everything is the utmost importance is the registered medical practitioner should be there, and the hospital is also registered. So the approval is we have to take approval in the form of the Form A, then Form B, and then the Form C. There are two new forms, Form E and D. We have new form introduced in the MTP Amendment Act. So there are total 5 forms nowadays: A, B, C, D, and E. And most important is the Form B and Form C. Form C is just like the consent form. Form E, this Form E and D are the newly introduced form. So these are the mandatory documentation under the MTP Act actually.
So thank you, yeah, Dr. Jyoti, as you have told that we all should know these 4, 5 or 6 documentation. We are not required to apprehensive or to get how we will maintain. Form C, don't forget to have first thing that you should apply on the registration of your center on the Form A. So all private center has to apply on this Form A. This is available on different websites. You can get from the Foxy websites also. And their Form A, you can see that in the category or B, whether it is in the first trimester abortion or second trimester abortion, eligibility criteria are different, infrastructure is different. You have to get it and you have to approve. So CMO team will come to inspect your center, and then they will give you this Form B. Though all of you, we should have this and we should display at our working area. If we are not having, then we can apply to the CMO FS, you can get it. Very common question that if we are having the second trimester, now the extension is done till 24 weeks. If this form is allowed or we have to apply for the new form? So answer is that you can continue it, but there is no harm if you can ask your CMO that you can renew till 24. Some places they are doing, some places they are not doing. If it is not doing, then if you are having the second trimester abortion approval form, then it is okay. then
Madam,
consent is very important.
But it is
there are
not
there,
mandatory. Because
actually, there are few places, Bharti madam, there are few places, just like in our Madhya Pradesh, there are only, we can go up, means we can take approval of only 2 hospitals in our, means if I am registered medical practitioner, I can do only in 2 hospitals. I can register in only 2 hospitals. So there are different type of thing for approval of hospital and approval of registered medical practitioner, apart from the MTP Act. The district to district and state to state also they differ in this particular opinion. Just like in our own city, I cannot go to any of the hospital. I only
Dr.
can go to
Jyoti,
this.
Dr. Jyoti, here we are discussing only the actually what act. Actually, there are lots of myths in the different states, different cities, and particular that city CMOs and all. So
Yes.
here we are discussing what is the by the government guidelines says, and there is some places where the CMOs or where the authorities they are practicing differently. So if you have some issues, then you can discuss that it is there, and we can because if your place is registered where you are going and you are registered, then you can go do at any
Yes.
place. But if
Yes.
some city arrangements are done in the differently for some other things, then it is different. So we all should know then form C consent is the most important medical legal aspect. Never forget to have a form consent on the form C. And then this is you can see the picture of opinion form 1, and this is the salient pictures of amendment as we have said that as the extension is done for 20 to 24 weeks. If some woman is asking for the more than 20 weeks, then you have to fill this form D, and you can see the indications are mentioned, and this is a different form, so you should have this form in your OPD. And as you have said that if beyond 24 weeks you want MTP, then you have to take permission from the medical board that having the gynecologist, pediatrician, radiologist, sonologist, and for this form is the form E, and here you can see that this is a separate form. You have to fill it. Those who want to download these forms, I will request ICOG Foxy that they make it available on their website, because many doctors they have issues that they are not having this form. Baki rest Dr. Isha is, can provide to everyone, and we are also trying to send to everyone. And this is the form 3 admission register. All of us has to fill this form and has to keep in the custody till 5 years, and this is a very confidential document. This form she admission register has not to share anyone, and it is requested by and it is said by the government guidelines that no entry of MTP has to be made in any case sheet, OT register, follow-up card, or any document or register other than admission register maintained at the facility. And nowadays also the new MTP Act amendment, this confidentiality law is very much highlighted, and it sealed that no registered medical practitioner shall reveal the name and other particular of a woman whose pregnancy has been terminated under this act except to a person authorized by any law for the time being in force. Whoever contravenes the provision of subsection will be punishable with imprisonment, which may extend to 1 year, or with fine, or with both. So you can say that how this confidentiality law is important. So these are the mandatory documents: Form C, consent form; Form 1, opinion form, which is the different for 20 weeks and more different from the more than 24 weeks; and then Form 2, it is common for the everyone; and Form 3, admission register. And these are the only documentation. So we should not be remain apprehensive for the documentation, but this has to be keep the OPD ready, and this has to be bring to our staff so that they can do it. Now the next question: what are the protocol for safe and legal abortion, and when it called violation of MTP? Already told by Dr. Mitra and Dr. Jyoti that when performed by registered medical practitioners as defined under MTP Act, it has to be performed at approved site. Form B should be displayed at your center. How you get it, you should know that. And then other requirement of Act such as Form C or Form 1, Form 3, it should be filled, and pregnancy should be within the gestation limits approved by the law. So, and if you don't do this, then violation of MTP Act, and it can have a imprisonment as well as fine. So this is the thing. Now, what facility you should have in the first and second trimester abortion? We all know that it should be in the first trimester abortion, except OT facility, you need all things, and the second trimester abortion, you should have OT facilities also. So now, Dr. Meena, who can provide medical methods of abortion, and does site need approval? Does all form has to be filled? Dr. Meena.
Okay, my this thing that is a little shaky. Anyway, yeah, like any registered medical practitioner who is an MD or MS, TGO, or somebody who has worked in gynae for 1 year or more or done HS, they can do. But for medical all those who have been trained for doing MTP, they can do. But apart from that, medical management can also be done by somebody who's worked in obs-gynae for 3 months and who has taken and who has directly observed with somebody who's trained to do in an institute which is recognized.
Madam,
So-
actually 10 cases, the RMP should have done the 10 cases of the medical method, and either means the
So,
10.
Dr. Meena, do missed abortion and complete abortion, they need to be full by MTP protocols?
No.
Yeah, okay, I know I'm slipping out. Yeah, again, they can do it, and they can do it even if the place the OPD is not registered, but they have to be, have a referral center which is recognized.
So basically, we all should
Hello.
know that for MTP we can provide the medical methods from the OPD, but we should be OPD clinic should be linkage, having established linkage with the approved site, and certificate to this effect by owner of approved site has to be displayed at OPD. Display word is very important. It should be displayed at your OPD clinic, and all records has to be maintained as we do in the other methods of abortion. Missed
And
abortion.
in case of emergency, the person who has actually, dispensed the tablet, if at all there is an emergency, the person should personally communicate to the center where the emergency care can be taken. That is what is most important. Displaying the certificate and communication for the emergency management.
Yes, yes. And second thing that none other just missed abortion, inevitable, spontaneous. This is like you are doing any procedure, you can do entry and in the OT register and doesn't come under the MTP Act. Now,
Yes.
Dr. Mitra, patient already taken MTP pill and come with excessive bleeding. Very common situation, and nowadays we are seeing in a lots of number with the even pulseless, BP-less. I am seeing daily in the emergencies, and how it should be managed actually.
So actually, I would say they have to be managed at two levels. One is the clinical management of a patient who is having incomplete abortion or whatever. She's coming with bleeding. So we have to do the clinical management on one side, and the other will be documentation. Both are important. So before we do the clinical management of patient, it is important that we should have assessed the patient, the general condition, taken a brief history, done the clinical examination, see if it's os is open, incomplete abortion or what it is, and do a at least minimum check of CBC, blood group, and this ultrasound. If the patient is, if we can do it, if we have it in our own facility, we should do, because it will help us in every possible way. And having, done the assessment, then we can go in for the evacuation of the patient. And what is very important in history is also to be very astute, that is it a middle trimester abortion which has come to you as an incomplete, or it is a first trimester abortion, because many, you may not get stuck in trying to save a life. Second part is the documentation. So whoever you've saved the life, you've, done the clinical management. The next part is the documentation, and there is a register for incomplete abortion, missed abortion, which has to be maintained. So if whether you use empty pill, even in that case, or you do surgical evacuation, you have to maintain a complete record of this patient who has come to you as bleeding case and whatever. So your both managements have to be done simultaneously, so that you save the patient clinically and you save yourself by.
So here, yes, madam, and here I want to highlight that we all obstetricians knows when the patient comes with a bleeding, either she is having incomplete abortion or she's antenatal case, we know that we do first the resuscitative management and then we find out what is the cause.
Yeah,
If like if one is, we are talking mainly in the after medical method, so we are taking the patient have taken the MTP pill and come with excessive bleeding.
See, what I will tell you, Dr. Bharti, in our part of country, because there's a lot of there's lots of sex determined MTPs. So middle trimester patients also take MT pills. They take misoprost over the counter, how they get it, and they come aborted. And then you look at the size of the placenta. So not MT
talking
pill
about the clinical management
regular.
of these cases. Failed medical method, patient is excessive bleeding, then definitely first thing.
Of course, a history will tell you it's a failed medical method or it is a abuse. You have to be astute as a practitioner. That's my take.
So basically, if vitals are stable, if patient is excessive bleeding, immediately at that time, whether she has taken already pills, she has taken from anywhere, that is a different thing. But first you have to manage vital stable, and then you can do ultrasonography And you
do
can
the
manage
clinical
by
management.
additional dose, 600 microgram. You can give additional that is a misoprostol. And if no sac is residual bits are there, then conservative treatment. Follow up after 7 days. But if patient is bleeding profusely, then fluid, oxygen, antibiotics, oxytocin, and followed by
That's
vacuum
what I
aspiration.
said.
Here
We have
I
to
want to
manage
highlight one
everything.
thing, that if you will use this follow-up form, it's not necessary that when patient is taking MTP from outside only, then she is bleeding. Sometimes we are giving the patient MTP pill, but we have to give this follow-up form. Here very clearly mentioned that once patient is taking the misoprostol, this is the guideline by Government of India. So once you are giving the misoprostol on the third day, then you have to observe the woman for 4 to 6 hours in your hospital. And second thing, if she is not bleeding in the 4 to 6 hours, then you have to ask her that come in the 20. If she is not having bleeding, then come in the 24 hours to the hospital. And because she can have ectopic if you are not we are not doing some ultrasound, and sometime at early stage it is not diagnosed also. So this is very important point, that when you give the mifepristone, then you have to give her a contact address, phone number, only then you can give her medical abortion. If it is not accessed in the moment, then you should not give her medical method. And then second thing, when you are call her on the 15th day, then it is very clearly things are there that you are not supposed to do ultrasound. It is not mandatory, but if you are clinically satisfied, otherwise you can do. And you ask a report back if there are no period within 6 period. Reinforce the contraceptive counseling and services. Again, on the first visit, contraception counseling is mentioned, and anti-D 50 milligram if RH negative. And if you are giving on the again in the third day, when you are giving misoprostol, you can give her for as a contraception method. You can give if you can, if she is allowed, she's agreed, and she can be given. And again on the 15 days you would give the contraception counseling, and you give, if you can give whatever it is indicated. So here the highlight is, first thing is the contact address you have to give, and second thing, you have to follow this form, give woman that when she has to report immediately, and on the 15 days record. And third thing, that contraception from pre-counseling to during procedure, and then after counseling, our emphasis is that she should get the contraception if it is required. So now come to the next issue, that is, Dr. Sneha, any 17-year girl come with a guardian with 8 weeks of pregnancy, because now we have discussed these are the challenges nowadays regarding MTP services. So this is a bachi, she come with a guardian with 8-week pregnancy, and she wants that she want to hide the things and maintain the confidentiality, and you just terminate the pregnancy. So
Yes.
what should be your approach, and what important thing you
Yes,
have to
Dr.
definitely
Bharti.
do in the brief?
Yeah, definitely the confirmation of pregnancy, the eligibility, and the procedure and protocol of consent, everything has to be the same. Only thing is, now this girl is less than 18 years, so we have to act according to the POCSO Act. We have to inform this to the police. We should not or need not wait for the permission, but it is a procedure to be followed to inform to the police, and then we have to go for the termination of pregnancy. According to this, the procedure, along with the routine procedure of termination of pregnancy, we are supposed to say, preserve the products of conception in normal saline, if at all it is to be sent for the TNA, as per it is required by the police department. So I think that is all. Otherwise, all the precautions, the procedures, safety, efficacy, everything, and the complications and things will be same. But we have to follow the POCSO Act, and we have to do the procedure according to the POCSO Act. That's
Very
all.
true, Dr. Sneha. We should never forget to implement the POCSO Act, and then we can do procedure with adult guardian, clinical procedure same as nulliparous cervix, and POCSO Act. We all must know that it is this is the Protection of Children Against Sexual Offences Act 2012, where it requires anyone who knows that a sexual offence has been committed has to report the appropriate authority, that is ideally local police or special juvenile police, or to the concerned authority in the hospital responsible for medical legal cases to report the same. Medical practitioners must remember that while completing the reporting formalities, it is also important to ensure that services are offered to the client and all documentation is maintained as per the previous provisions of the law. And here one important very thing is that medical practitioners are not obligated to file an FIR or conduct an investigation. The provider's duty is only to inform the authorities when providing services to a minor, including abortion services. Under the existing provision of MTP Act, legal proceeding, if any, can continue simultaneously and should not be hindrance in the management process. And nulliparous service, of course, young girls and they are having or any nulliparous service, the service prescription is very important. We should learn that tablet misoprostol 400 microgram 3 hours prior to procedure can be given. If it is not still sufficient soft, then we can do additional one dose 200 microgram in the vagina. Alternate of misoprostol, you can give Serviprime or PZE2 or catheter balloon or whatever you want to do. Sometimes some give the PGF2 alpha or prostadine. Syntocin infusion additionally in the distance cases, because this is really very challenging. We all know that in nulliparous cervix to soften and to efface, and hysterectomy consent is also sometimes required. Now to Dr. Meena Samant madam, that 28 years woman, 21 weeks pregnancy, having congenital anomalies with previous 2 cesarean, and she comes to you with abortion. What are the important things you will check it before taking the decision? Yes, Dr. Meena.
Okay. Here we have two things. One, that the baby, which is abnormal, and now she is willing to go for an MTP, and it's a previous 2 section with 21 weeks of pregnancy. So counseling, I know we are too rushed, but our counseling has to be very, easygoing, not rushed, in a quiet place with one-to-one eye contact, with confidentiality and dignity. Everything has to be maintained, and in a very non-judgmental way we have to counsel. 21 weeks you have already said, and so we take that it's something where the MTP has to be done. So counseling part would include telling why it is needed, what are the methods available that can be and which she can choose, and we can help her, come to the decision and which method would be best for her, telling how much time it will require, the pain management, the infection prevention, the risk of hysterectomy being undertaken because the scars are there. Both surgical and medical methods, one leading to another, could be there. Then, of course, the post care has to be told to her. Then, because surgery may be needed, so any infections, the STIs, those things have to be taken into
So basically
account.
we have to,
And
yes madam, yeah. So we have to confirm the gestation age. This is very important, confirm the pregnancy. And as you said that it is a 21 weeks pregnancy, then again I have told you for the 20 to 24 days of Form D that has to be filled. I have shown you in already, and it can be available if someone wanted. And then as you said that first we have to find out confirm the indication also, whether she is eligible at the 21 weeks, the congenital anomalies, whether it is incompatible with life or it is indicated in the according to MTP Act or not. And then 2 opinions has to be taken because it is a 21 weeks pregnancy. And then of course again comes to the point that successful termination, we should have a skill enough, and we should have we are having the facilities and skills to manage the complications, as well as we should have logistics also, because second trimester abortion, they always should be the IPD. In the indoor process, they should have skills, and they are prone for the complications. So we should remain anticipation for this, because around 60-70% complications have both higher morbidity and mortality are in the second trimester. And as she is a previous to scarred, then care for scarred uterus. And again here the scarred uterus, this is a very important issue that we want to know what evidence says for the use of misoprostol in the scarred uterus. So here lots of studies, and they all say that we have to individualize the dose. Like if she is having the two previous cesarean section, then instead of 400 milligram vaginally, you can use 200 milligram vaginally every 6-hour interval on first day, and then double the dose to the 400 gram the same interval the second day. So it is seen that even that in the 3 or more prior cesarean section, it is safe, and the many studies are there that there are no ruptures, and the success is there. And again misoprostol treatment is equally acceptable, no doubt, but you have to counsel the patient, you have to take the consent properly, and have to tell the patient all consequences what can be happen, and have to remain anticipate, and have to remain all arrangement. So Dr. Sneha, what is the special precautions in the scarred uterus, briefly? Dr. Sneha, you there?
Madam, actually, we should fill the Form E also. This is the opinion form for we should have the opinion of the 2 doctors.
Yeah, opinion form I have said that Form D, it is a difference because
Can I answer the question, Dr.
It is Form E, madam. Bharti madam, it is Form E.
Form
yes.
E. Yeah, documentation has to be complete. Can I take the question of management of this patient? So,
yes, you take
like,
the management.
like you rightly
In the
said,
brief,
this
yeah.
patient needs to be investigated, counseled, and tell them about the time. Most often, the patients are very worried and they want a very quick job. Here is the real catch. If we explain to them that by medical methods, we will be successful most often, provided we give time to the uterus to act, the medicines to act on the uterus. The safest method to do is two-step, that is ripening and then initiating the uterine contractions. Knowing well that there are two scars, that is why we have to be very cautious. So in, the most important and successful methods are, you do the ripening with Foley's catheter, and then after 12 hours or so, you start a oxytocin drip. In my personal practice, what I have started doing is I use Mifegist, tablet, 1 or 2. In fact, I double the dose and I increase the interval. I do not start misoprostol immediately. I give a little gap of 48 hours to 72 hours. And I have found excellent results. I don't even need to give 200 micrograms if I have ripened the cervix with Mifegist. And then I titrate the dose of misoprostol. Instead of using 200 microgram, I'll start with 100 microgram, because, you can see the effect of 100 microgram as well as 200. So start with low and make it, give the interval should be tightened or tailored according to the patients. You try
This all will discuss in detail, I think, by the
that is a question for me.
second trimester, yeah.
So,
yeah.
medical methods. And lastly, of course, if it is not successful, then patient has to be prepared for hysterectomy.
Thank you. So this was about the second trimester abortion, and in the 3-4 minutes we have to wind up. So like this is the one only issue, that is a 24 years woman come for 10-week MTP having 2 girl child already. So how you will approach? Only 1 or 2 lines, anyone? Dr. Meena Samant, what you say is that you will refuse doing MTP, you will suspect that she is having for the gender, she is a gender bias, or you will take this?
We have to, ask the history. Yeah. Just because has 2 children, we have to be sure whether it was a failed this thing. What is the reason why she is wanting to go for an MTP? Usually at 10 weeks, it's not, the ultrasound is not going to tell us that whether it is a male or female. So I think that doesn't, probably, maybe it may not be the case. So really looking into what is, because we are doctors from 1 to why the reason for the MTP we have to assess. And just because there are 2 sons or 2 daughters.
Yes, so what the guideline says, we should see that our guidelines, Government of India says that national policy is to make abortion safe and widely available as per the law. Abortion is legal for a number of reasons, but not for selection the sex of the fetus. Even today, 8% of maternal mortality is due to unsafe abortion. So safe abortion services should not be jeopardized in preventing sex selection. Estimate indicates that about 9% of abortions are sex selective and 90% are not.
Dr. Bharti? Dr. Bharti?
Abortion will involve female fetuses, and this will be true regardless of sex ratio of that area of level of compliance with the law. So this should not be like taken that that's why our all mottos that safe abortion services should not be jeopardized in preventing sex selection. Surakshit Garbhapat Beti Bachao ke saath, so these services should not be hampered. So quick issues and role of ultrasound, it, of course, it should be it is helpful in the accurate dating, but it is not mandatory as per act, but it should be used, and even the scarred uterus, it should be used. Approach for MTP flowchart, I have already discussed. Mandatory documentation under the MTP Act, we all should know that Form D and Form E, this we should enter in our files. And then last question, what awareness among doctors and public required? Our panel have started from this. And again, in the ending with this, कि क्या awareness होना चाहिए one by one. Dr. Dr. Meena Samant, what think that about the MTP acts and the skills you agree that this awareness is required in the doctors as well as in the public also. So Surakshit Ho Garbhat Beti Bachao ke saath we are doing lots of efforts from Foxy since many years that we should spread in all over countries, and I think that in last 5-10 years awareness has been increased regarding the documentation of MTP. Even WHO is also talking that how to make comprehensive abortion care in access of each woman. And WHO also says that regarding safe abortion, respect for women informed and voluntary decision making, autonomy, confidentiality, privacy with attention to adolescent and women with special need. So all obstetrician has to taken care of all these, and access to safe abortion depend not only on availability of services, because we all know that data says that in the government services or in the authorized services the women taken less services rather than the unsafe abortion, because we have the services but it also depends on the manner in which they are delivered and the treatment of women with the clinical context. Services should be delivered in a way that respects women's dignity, guarantees her right to privacy, and is sensitive to her need and perspective. And beside that, this is the moment-centered approach according to our MOHFW Government of India, that we should devote adequate times for counseling, maintain privacy, use safe technologies, follow standard protocol for infection prevention and pain management, offer post-abortion contraceptive services, provide reproductive and other health services and services tailored to a woman's medical and personal need. Again, these all publications, they are available, and these are the things which you can go, like Comprehensive Abortion Care Guideline 2018 and Ensuring Safety and Well-being of Women, Amendment in Medical Termination of Pregnancy Bill 2020, and Dr. Nodha Shrial sir will speak on it after a few minutes. And in the last litigation regarding MTP can be only avoided by counseling, documentation, improving skills, and of course know about the act. So thank you very much for all panelists and all experts. And we come to the next topic. Richa is there? Richa?
Thank you, Dr. Bharti.
Dr. Richa?
Thank you, Dr. Bharti.
Thank you,
so much.
Dr. Bharti. Thank you very
Yeah.
much.
Yes, I'm there, Dr. Bharti.
Yeah, Richa, share karo screen apna.
I will just share, and I have mailed to you also. I think this laptop now I have just changed.
अगर तुम्हारा इशू है तो मैं देखूं, मैं अपनी मेल से करती हूँ. ओके, रिचा का आया, मैं करती हूँ, मैं शेयर करती हूँ जैसे.
I think you only have to share, because I don't know why options are not coming at my end this time. आपने स्क्रीन शेयर स्टॉप किया है ना भारती मैडम?
हाँ, मैंने कर दिया. अगर तुम अपना ट्राई करो जब तक मैं तुम्हारा वाला डाउनलोड कर रही हूँ. हो रहा है वो मेरा. तुम एक बार ट्राई करोगी खुद से?
हाँ, I will just see.
करो. बड़ा समझ, ये ऐसा प्रॉब्लम कभी आता नहीं है ना?
हाँ, I don't know कि what.
हाँ, ऐसा क्यों? I don't know. रिचा?
हाँ, I can see.
मैंने शेयर कर रही हूँ, मैं तुम्हारा शेयर कर रही हूँ. ये मैंने शेयर किया है, ठीक है? You just start, yeah.
ठीक है. Okay, so a very good evening, everybody, once again, and apologies for this inconvenience. And I bring greetings from UCMS and GTB Hospital, Delhi. So now I will be covering second trimester MTP. Now much has been talked about in the panel, so my job is fairly easy now. So MTP, we all know it is a small procedure, but then we must know it is governed by the Act. And why the Act was devised is basically we have to protect two people, one mother and one the fetus. So terminating a pregnancy is a choice of a pregnant woman and a part of her reproductive rights. And at the same time, the country has the obligation to protect the life of the fetus. So that is why the conditions and everything has been laid down. Now, the MTP Act Amendment 2021, it was a long journey, and it was implemented on 24th September and notified on 12th October 2021. So next slide, please. So MTP Act, we all know it is all about who, when, where, and documentation. Next slide. So MTP Act clearly tells us the person who should do the MTP, then what are the indications, then the place where we should do the MTP, and then the most important is the documentation and the paperwork. So now strictly speaking about the second trimester MTP, please go back to the previous slide. So second trimester MTP is now who can do the MTP? Bharti madam, can you make full screen slideshow?
Full screen नहीं है?
नहीं, it is not.
अच्छा अच्छा. Okay.
Okay.
Now
Can
it
you
is.
go back to the previous slide?
अभी full है?
नहीं नहीं, पहले वाला.
अच्छा पहला slide दिखा रहा.
हाँ, तो who can do the MTP now? Second trimester MTP, that is after 12 weeks. Now the any registered medical practitioner. Now registered medical practitioner means they have a recognized medical qualification as defined by the Indian Medical Council Act, and also their name is there in the state medical register. So any a practitioner who has a PG degree or a diploma in obs and gynae, they can do the MTP in second trimester. And also the MBBS doctors who have two criteria. Either they have 6 months of complete house surgency in obs and gynae, or they have 1 year of experience in obs and gynae. So they can also do the MTP in second trimester and after that. Now coming to the opinion, who can give the opinion? Now RMP who has one RMP opinion is needed if we want to do the MTP for less than 20 weeks, and 2 RMP's opinion is needed if we want to do the MTP between 20 to 24 weeks. And after 24 weeks, it is the medical board discretion. Please change the slide. Now the medical board has the authority to give the opinion for those cases who are having the congenital anomalies after 24 weeks. Now in our country, almost all the states, they have constituted the medical boards, and now the medical boards are functional also. And the members of the medical boards are important. Has to be a gynecologist, pediatrician, radiologist, and also any other member which the state may notify. Now, once the medical board gives the approval for yes for the particular MTP, then the two gynecologists have to perform the MTP. That means the two gynecologists' name has to go for the MTP beyond 24 weeks. Next slide. Now, the medical board, they have the power, they can invite the other specialist also to the board for taking the opinion, and they can say yes, and as well as they can say no for a particular MTP also. So after 24 weeks, MTP is only for the congenital anomalies which are incompatible with life, and also those anomalies where there is a risk that the baby will be born with a serious physical and a mental handicap. So those anomalies are included in that. Now the medical board, they have to give the opinion within 3 working days, and once they give the approval, then it is their duty to see that the MTP is done within 5 days of giving the approval. Now, next coming to the indications. Now, these are very important. We have to know that the gestational upper limit, it is increased in certain category of the women. So, second trimester or up to 20 weeks, there are the same old 5 indications to save the life of mother, then humanitarian grounds, then if there's a risk of the mental, physical or a mental injury to the mother, and the contraception failure, which is covering both married as well as unmarried women. Now, beyond 20 weeks, now there are 7 categories. So those are the survivors of the sexual assault, rape, victims, incest, minors, and unmarried women are also included in the category. And then if the woman has become widow or divorced, or if she is a physically disabled or having mental abnormalities and congenital anomalies. And the last category is the woman with pregnancy in humanitarian settings. So after 24 weeks, we have to understand very clearly that it is only and only for the fetal congenital anomalies. And there is no gestational upper limit. Now medical board, it is left to the medical board to decide. Now coming to the place where we can do the MTP in second trimester. Now second trimester, district hospital, they can do MTP up to 24 weeks, and medical colleges, they can do up to and beyond 24 weeks. Now the government hospital, they don't have to take any approval. They are already approved for MTP. But if it is a private hospital, they have to take the approval from the government, that is a district level committee. And documentation has been talked about, but again, I want to reinforce this point that the 4 mandatory documents has to be filled. Consent form C has to be filled, RMP opinion form, depending upon what period of gestation you are doing the MTP, that is form 1 or form E or form D. Then monthly reporting form has to be filled, and then the form 3, which is most important, that is a admission register for case records. Now the various forms have already been shared, so we can quickly skip. So this is the format of the consent form, and I assume that everybody is aware of these forms. Can you change the slide quickly, madam? This is a form 1. This is a format if we want to do the MTP till 20 weeks. So there are the indications are also written where we have to take which is the most appropriate one. So in case you forget, you can refer that. Next slide. Then the form E, if we are doing the MTP between 20 to 24 weeks. Now the 2 RMPs have to sign. Now this is the format. Now serial number is very important. We have to assign the serial number to all the women who are coming for MTP. So this I will be telling you later. So next, this is the format of the form D for MTP beyond 24 weeks. That is by the medical board approval or denial. Now, this is the format of form 2, monthly reporting form. We have to fill this form and we have to send to the district authorities first week of every month. Now, this is the most important form. Actually, it is a register. You have to make your register this way. 16 columns has to be there. And each woman will be assigned a particular serial number. So once you give a serial number, then thereafter all the papers should have the serial number and not her name. And all the forms are very important, medico-legally confidential. So you have to preserve for 5 years at least. Now coming to the second trimester MTP, now whenever we want to do the MTP beyond 12 weeks, the patient has to be admitted. You cannot do the OPD basis MTP. Now detailed history, physical examination, investigation and pelvic examination, everything goes without saying. Now most important thing in the second trimester is that apart from taking the consent in form C, always take a high risk consent also, and a pre-anesthetic checkup should be done, and always counsel the patient about the method failure. So in that case, either you will be repeating the method or you will be going for the surgical termination of pregnancy. Availability of the attendant is very, very important. Now, mifepristone and misoprostol drug, they are the wonder drugs. It has been elaborately discussed by the first speaker and in the panel also. So if you see the Government of India Guidelines, Comprehensive Abortion Care 2023, also they have clearly mentioned that mifepristone and misoprostol for termination of second trimester pregnancy is not yet approved by DCGI. However, WHO recommends this method as the safest method. So WHO 2023, and now the FIGO has also come up with a new dose regimes 2023. This is the chart which I am showing you. So next, can you go to the next slide? And even the FOXY GCPR also 2023, we have formulated all the doses. So this is the compiled dosing chart which we have taken from all the recommendations. So always better to use the combination regime, that is mifepristone 200 milligrams orally. So this dose remains the same, either you are doing MTP at 12 weeks or 24 weeks, 28 weeks or beyond. But if we are doing the MTP between 12 to 24 weeks, the misoprostol, the dose has to be 400 micrograms. And then if you, from 25 to 28 weeks, you decrease the dose to 200 micrograms. And then after 28 weeks to 100 micrograms. So you have to repeat this dose every 3 hours. Every 3 hourly it has to be repeated. Now initially the 5 doses was the upper limit, but now that upper limit has been removed. So you can put the 5 doses, and as per your clinical findings, you can put the additional doses also. or you can stop there and give the rest for 12 hours. Now, initially we were giving for rest for 24 to 48 hours, but now the rest of 12 hours is recommended by the new FIGO guidelines. So in that case, or and even the grand multiparous women also, mifepristone is not at all contraindicated. And always the combination regime is always better than using the misoprost. One thing we have to understand very clearly, that the interval between mifepristone and misoprost has to be at least 24 hours. Next slide. So now, apart from the mifepristone and misoprost, now the WHO 2023 has also said about the tablet letrozole. Now, letrozole can be used up to 14 weeks of pregnancy. So the dose of the letrozole is 10 milligrams for 3 days you give, and then 24 hours gap, and then use the misoprost. So there also the success rate is quite good up to 14 weeks of pregnancy. Now, another method which has been recommended by Government of India is the mechanical method, that is using the Foley's catheter in the extra-amniotic space, and this really works. Now, always there is a question like how much saline we have to instill in the balloon. So it all depends upon the size, which what Foley's catheter you have taken. So you instill 5, 10 or 30, and depending upon the capacity, and apply a good traction and leave it for at least 6 hours to 12 hours, or let the Foley's catheter fall off and then supplement by oxytocin. Now, ethacridine lactate should not be used. In fact, it is not available in the market at all. And hypertonic saline also, which was once there and now it is in theory, it is not to be used. It is having a high toxicity. So it is not recommended by Government of India and not even by other bodies also. Next slide. Now, most important dilemma is there if we are dealing with the cases of prior scarred uterus. Now, the scarred uterus, as we all know, there's a chance of rupture is always there, but the evidence regarding this is very much limited up to 26 weeks. So up to 26 weeks, there are the various papers they have recommended that decrease the dose of misoprost or increase the duration to 6 hours rather than giving the gap of 3 hours, and do not cross 24 hours. 24 hours is the maximum limit. And even the mifepristone also, if we use a regime of 200 milligrams 3 times a day for 48 hours, the success rate also is very good, that is 63 to 75%. Now, the FIGO 2023, they have come with a statement that misoprost is safe up to 28 weeks in the cases of cesarean delivery, but it is not recommended in the women after 28 weeks of gestation in a previous cesarean delivery. So we should not be using misoprost as per the recommendation. Now, the troubleshooting is always, can you go back to the previous slides? The troubleshooting is always there, and I think it has been already discussed. One thing I just want to highlight, whenever we are doing the second trimester, MTP investigations has to be done, and ultrasound also has to be done, because of course we are going to rule out the anomalies, and even the uterine anomalies is very important, and then the placental localization, and also we have to rule out the placenta if the previa is there or other complications are there. Now, suppose you have given a one drug regime and patient has not responded, give her the rest. But before giving her the rest, always evaluate the patient. Don't hesitate to evaluate, because there can be the chance there can be a rupture of the uterus, or if there is a, can you go back to the previous slide, madam? You have come to the end. Yeah,
I
I'll
am
be
seeing
finishing very
how many
fast.
slides are left, because in 3
Yeah,
4
yeah,
minutes
no,
I
no.
have to give to Noja. Yeah.
Yeah, just 5, I think.
Yeah.
Four, yeah. So previous slide.
Okay,
So
okay.
don't hesitate once you have failed in your regime. Don't hesitate to reevaluate the patient. Only you, and always do the ultrasound, rule out the rupture of the uterus, and also rule out the wrong dates. And if everything is fine, give her the rest of minimum of 12 hours, and then start the regime all over again. Monitoring is very, very important. You have to monitor the patient. And ultrasound after the completion of the abortion is not at all required, just for the sake you want to document that the abortion is completed. So we should not be doing the ultrasound after the MTP, but if the patient comes with bleeding or infection or pain, then of course you have to do the ultrasound. Next slide. Now coming to the next slide, madam. Now the surgical method, now it is very much limited. Now the Government of India 2023 And even WHO, they have clearly said that dilatation and evacuation should not be done beyond 15 weeks of pregnancy because it requires a high level of expertise. And then we have the alternative, that is a mifepristone and misoprostol drugs. They are the really good drugs having the good success rate. Then hysterectomy, of course, it is a last resort which you have to take. So always take the consent for the repeating the regime and also for the surgical termination. Now this slide is very, very important. Now the induction of fetal cardiac asystole before abortion or feticide before MTP or induced fetal cardioplegia. Now since we all know that the MTP, the gestational upper limit is increased, there is a risk that the baby can be born live after the medical method and even after the cervical priming in the cases of dilatation and evacuation. So if the live born fetus is there, it is a source of emotional anguish for the women and also the wastage of the healthcare resources. So now WHO, FIGO, RCOG and FIGO 2023 and even the GCPR also, now we recommend that feticide should be done before doing the MTP for the cases who have come after the period of viability. So feticide, now it is a very important procedure. It can be done by any gynecologist who is confident enough of doing the feticide, or even the fetal medicine specialist can also perform that. But we have to take a well-informed consent has to be taken, couple has to be informed properly, and PCP and DT Act, all those forms has to be carefully filled because it is ultrasound procedure and we are going to giving the drug into the fetus. Now 3 drugs are recommended, that is injection potassium chloride intracardiac we can give. The success rate is very good. The cardiac stoppage occurs soon after giving the drug, but intracardiac injection, it requires the high level of expertise, and 4 to 6 milliequivalent is the dose. So injection digoxin or lidocaine, it can be given. Now we can give in the intraamniotic space. It has to be ultrasound guided procedure. And once digoxin and lidocaine, they take some time to get absorbed and then to act. So you have to document that the heartbeat has stopped and then proceed with the MTP, or you can repeat the dose. So the recommended dose for digoxin is 1 to 2 milligrams and lidocaine is 200 to 240 milligrams. Next slide, madam. Next slide, please. So the procedure has to be under aseptic precaution, that goes without saying. Hemostasis has to be maintained and confirm the asystole and then start the MTP. But there are few centers who are not able to do the feticide before MTP, so you can refer the patient to other centers, but always counsel, and all necessary documentations and counseling part has to go, that goes without saying. So this is about the second trimester MTP, and if the MTP Act it is contravened, we all know the rigorous imprisonment is there. For if a person who is not authorized to do the MTP does the MTP, or a place if it is not approved, documentation is very, very important. Record keeping is very important. Why? Because now there is a 1 year of imprisonment and also the 1,000 rupees of fine, which was already existing earlier on the concerned person. So with this, I end my talk, and take home message is just follow the protocols, follow what has been given by the MTP Act, who, when, where, and documentation, and so that you will be medico-legally safe and your patient will be physically and mentally safe. So it is better to be safe than sorry. So
thank you, Dr. Isha, very comprehensive, and you have covered second trimester abortion in a very short
and I
time.
know I was just rushing through. I was trying to cope up the way you were changing the slides. So anyway,
you
thank
made,
you, Bharti madam, for sharing the screen, and thank you everybody and ICOG for giving me the opportunity.
Okay, thank you. So now we come to the next session, and I invite our chairperson, Dr. Harish Doshi sir is there, and I just request sir, Dr. Harish Doshi sir, we all know that he was the vice president of our Foxy, very dedicated Foxian academician, and he's here in this today's session to just share a session. Dr. Nojar sir. So Dr. Harish Joshi, we all know that he's a professor and head GCS Medical College, Ahmedabad, as well as had lots of publication, 7 books, booklets, 23 book chapters, and 35 scientific paper published. And the faculty in more than 250 times in national and international corner, President AOGS 2003 and SOGOG 2004, organizing secretary for AICOG 2000. So now to Harish Joshi sir for introducing Dr. Noza Sheriar sir, and he is with us to deliver a very important topic talk. So Dr. Harish sir.
Good evening, everybody. At the outset, I am extremely thankful to Foxy President Dr. Jaideep, Foxy's Secretary General Dr. Madhuri Madam, ICOG Chairperson Dr. Parul, Vice Chairperson Dr. Sheila Mane, Secretary Dr. Sarita Madam. Also, I welcome today's chief guest, Dr. I think Parag and Madam Sheila, Lakshmi Sekande are guest of honors, and chief guest is the past chairperson, right, from Navi Mumbai. Well, I must thank the conveners, Bharti Madam, Ranjana Madam, and Subha Gutti Madam for giving me this opportunity to chair this session. Doctor, I have a great pleasant duty to introduce him. Dr. Nozer is like Dr. Parag, I would say, a handsome, foxy faculty and stalwart, right, academician. If I don't have the slide, I will read from my mobile. He was a past Secretary General of Foxy and also committee chairperson of MTP committee, past president of Mumbai Obstetric Gynec Society. He is attached to Breach Candy Hospital, Hinduja Healthcare, and Holy Family Hospital in Mumbai. FRCOG, AOFOG Young Gynecologist Award, Chair Scientific Committee of 22nd FIGO Conference in Brazil, member of Technical Advisory Group WHO Southeast Asian Region, co-chair Medical Advisory Panel, Family Planning Association of India, Director, Buttermajor Institute and Center Catalyzing Change. He has edited 16 books, published 35 papers, and 70 book chapters. He is recipient of 2 Great Foxy Award, Dr. Hasotia Best Committee Award, and Dr. Datsda Best Publication Awards. Also recipient of 4 MOGS Awards, Dr. Bhatia Young Scientist Award, Dr. Ganatra Community Service Award, Dr. Desai Excellence Award, Mr. and Mrs. Pandit, right, Women's Empowerment Awards. You must have noticed that rather than national, is more affiliated to international association. So it's a real international faculty, and for the field or subject of MTP is concerned, he is the ultimate authority, last authority, I would say. Sir, we are happy to have you here, and sir will be telling us about the new MTP Act. It is not new; it is the amendment of 2021, enabling the environment for safe abortion. Dr. Nozer Serier, please.
Thank you, Dr. Harish sir, and I am just want to share that I am so grateful to Noza sir that whenever I ask or I request her to contribute anything for MTP related, either Foxy Focus or webinar, sir, I know that even at a very short time, sir agreed. So, sir, really thank you very much, and we are really keen to hear your topic. That is very interesting topic you have chosen. Please share your slide.
Thank you, Bharti.
Just 1 minute. I was just sorry, sir. When entered in Foxy, a toddler, I would say, he has guided me and helped me a lot. Thank you, sir.
Thank you. Thank you. Harish, I hope you all can see my screen.
No, it is a blank screen, sir.
I'm sorry. I'll have.
It is written there. You are viewing Nozer Serious screen.
I'll stop share and
now your photo has come. Yes.
Yeah, I'll just stop share and
do it again, sir.
You can see that?
Yeah.
Yes, sir. You can.
Yeah,
Thank
we
you.
can.
Your
We can.
screen is
Bharti,
visible.
Bharti, thank you. And thank you for requesting Harish to be there to chair this session, because we have a very, very special relationship. True academician, great teacher. And of course, this is an ICOG program, which is so special to all of us. So the task I've been given today is something that I got very passionately involved with, obviously through my responsibility as the chair of the MTP committee. Can you believe it? When Dr. Hansotia asked me to be the MTP chair, my first response is, no, no, madam, please give me some other committee. She insisted, and that changed my life. This was a picture I'd seen in Time International much before my time actually being involved with MTPs. It was a picture from Time Life. The country was Chile. This was a doctor who was, you can see him consoling this woman, and this woman came and told him that this had been her 26th criminal abortion. 26 times this woman puts herself at risk because Chile was a country that didn't allow abortions for any indication. And Chile was also a country which didn't allow contraception. Now, we seem to be very sometimes proud of the fact that we've had an MTP Act since 1971. Why then, in 2018, did a woman come to one of the hospitals I work at in Bombay with this little thing that was removed from the uterus by a colleague of mine? She shouldn't have had to do it in a country where abortions are legal and should be easily available. And my take on this is that when you don't give women the access to safe abortion with dignity, she will access abortion anyway. And that's where our responsibility as gynecologists, champions of women's health, advocates comes in. Now, I'm going to throw a few questions to you. You don't have to answer them on chat. These are beliefs, self-beliefs. Do you believe that an abortion should be available on demand? Remember, in India, abortions are not available on demand. Do you believe that easy availability of abortion make women careless with contraception? Do you believe there is a need for the husband to be formally involved in the decision-making process? Do you believe there should be an absolute upper limit for induced abortion? And finally, do you believe that a decision like this should be made by a committee of experts? All these questions, we will revisit them at the end. But today we are going to talk about something very important. And remember that the MTP Act exists to protect us from these sections of the Indian Penal Code. These sections still exist. Section 312 says anyone voluntarily causing miscarriage is punishable by imprisonment and/or fine. Interestingly, this section also applies to women, because a woman who causes herself to miscarry is within the meaning of this section. Sections 313 to 316 are death during procedure, up to 10 years of imprisonment and fine, again extending to life in imprisonment when abortion is conducted without consent. The MTP Act protects the practitioner from these sections of the Indian Penal Code. But I just like to say one thing here. What protects the woman? When this law was written, women weren't really causing their own abortions. But recently with medication, the reality is self-induced abortions, self-managed abortions. And that's a discussion I'll have with you at the end of this presentation. So Plato said, good people do not need laws to tell them to act responsibility, but bad people will find a way around the laws. Let me talk to you all about the new MTP Act today. I believe it does enable the environment for safe abortions, but I'm also going to talk about a wish list, what we had asked for, what we got, and maybe what we should keep asking for in future. So this Act of 1971 was Act 34. It was a landmark act. We were among the earlier countries in the world to have this act. We had the most amazing health minister under Indira Gandhi at that time, who managed to push through this act. Visionary. This act was not a punitive act. There were no punishments in the original MTP Act. It was a protective act. And obviously later on it got enforced nationwide after 1972. And remember, Kashmir and Mizoram were special situations. 317 Kashmir and 371 in Mizoram allowed them to make their own decisions, but they also accepted the MTP Act. In 2002, we had Act 64. This was the first amendments. I can be so proud because Foxy was part of the first act. Foxy was part of the amendment, and I was really privileged to be at the table and literally do all these things. The main changes were we removed the word lunatic and made it mentally ill person. Lunatic was very restrictive. We had district level committees because we had instances in Foxy of people waiting for 7 and 10 years to get approval. And for the first time, the concept of punishment was included. Punishment for people who did an MTP in a non-registered center or for a non-registered person doing an MTP. We also changed the rules, and for the first time, we differentiated first and second trimester terminations. So we said you could now do a first trimester termination in a very simple setup with just a gynac or a labor table, backup for treating shock and transportation. Nothing else, no OT, no lights, no OT table. Second trimester terminations required all that. We also brought a restriction where first trimester terminations could be done by an MBBS doctor with training, but for a second trimester termination, you had to be a gynecologist. We also brought in this statement which allowed medication abortions. People said gynecologists won't allow medication abortions, and today 80% of abortions in our country are medication abortions. But there were arguments that you are supposed to do it in a registered center. So do you administer it in a registered center? Does she sit there till she aborts? So we did something very clever. We said that it may be prescribed by any RMP who has access to a place approved. So you can be sitting wherever you want, as long as you have access to a facility or a friend's facility or hospital, you can prescribe medication abortion. And then came Act 8 of 2021. It further amended the MTP Act. It was the 72nd year of the Republic of India. It came into force by the central government, and it was legislated by Parliament on the 25th of March 2021. Now, I will just highlight the important differences. On the left are the old Act, on the right are the new changes. The first thing that we did was a pregnancy may be terminated by an RMP up to 20 weeks. Okay, now just remember, 20 weeks still remains the benchmark for most MPPs. But between 20 and 24 weeks, we created a category for vulnerable women. When we were negotiating, we worked on this from 2005 to 2010. The Women's Commission came in and said, we would like it to be extended to 28 weeks. And we explained to them to have a normal fetus coming out at 26 or 27 weeks is very difficult because we don't have feticide in our country and people would not accept it. So we decided 24 weeks. And the big change was up to 20 weeks, you do not need a second opinion. Between 20 and 24 weeks, you need 2 opinions. The next very simple change was asked for a long time, wasn't given initially. The contraceptive failure was by a woman or her husband. Now it is by any woman or her partner. It's common sense. It's a no-brainer. It was a very different world in 1971, but today we've accepted it. The third thing, and this is extremely important, that the provisions relating to the length of pregnancy, 20 weeks or 24 weeks, shall not apply to a termination because of substantial fetal abnormalities. The only thing is this had to be approved by a medical board. Now there I have certain problems, and I'll tell you why as we go along. The section 3 goes ahead to put a 2C, which says that every state government or union territory shall constitute a medical board, and the medical board should have a gynecologist, a pediatrician, a radiologist, zoologist, and other members. Now, this was something that we managed to introduce at the last minute. For the first time, confidentiality came into the act. Till now, the confidentiality was only in the regulations. Our hope was that this might protect our practitioners from the problems associated with POXO Act, but that's something that the lawyers will have to help us out with. So no RMP shall reveal the name or particulars of a woman to any person except to a person authorized by law from a time being. So what we thought would happen didn't happen, because a person who's investigating, as was in the past, or even someone who comes under the POXO Act cannot claim confidentiality. And then, of course, there is, again, the problem with the laws today is every law is a punitive law, punishment. So even for something like this, there is a punishment of 1 year and fine. Then there were the rules and regulations, which was the amendment which allows them to make rules and regulations. And I came across a very interesting discussion in Parliament. You know, members of Parliament, we think, are just shouting and screaming all the time. This was a very thoughtful discussion. The law came in, a number of members, particularly from the opposition, said, you have to have increased awareness about legality and availability, because most people are not aware that it's available or it's legal. You have to combat stigma. We know that. Interestingly, the parliamentarians agreed that training and permitting nurses, ANMs, and Ayush practitioners to provide first trimester abortions in rural areas with no allopaths. They suggested setting up fast-track course for minor rape survivors, steps to be taken where the fetus is alive, a big problem because we do medical terminations and a fetus may be born alive. Providing paid maternity leave for women who undergo an abortion, and omissions in the bill such as approach to needs and rights of sex workers and transgenders. I think that you can agree that this was a very thoughtful discussion in Parliament. Now, whenever you amend an act, the act has to be then applied to the rules. And then you come up with the rules, which is how the whole system works. So the rules came into being on 12th of October 2021. The rules come from the ministry and they go back to Parliament only for ratification, not for much discussion. This is the first rule, the extension for vulnerable women, survivors of sexual assault. If the marital status changes, if suddenly she becomes a widow or a divorcee, physical disabilities, mental health. Now, we made a mistake last time. Last time we left out mental retardation. This time we are saying mental health, including mental retardation. Because in the past, there was a case in Punjab, if you remember, a very severely mentally retarded girl. The institution wanted to terminate the pregnancy. And some activists came and went to court, and court said, but you haven't mentioned in the act and the amendments mental retardation. So we changed that. Fetal malformation, substantial risk of abnormality if the child were born, and pregnancies in humanitarian settings, disasters, emergency situations, war situations, crime situations, all those get covered by this. We then have a Form E for these vulnerable women, and you can see the A, B, C, D up to G, but there was one mistake made. And that's why I say we have to be very vigilant. Anyone who represents Foxy has to be so vigilant, because originally when we had a discussion, we had clearly said unmarried women. And in this we said widowed, we said divorced, but someone forgot to mention unmarried. And luckily, after that, it went to the Supreme Court, and the Chief Justice of India, Justice Chandrachud, who's an amazing champion of Reproductive Rights said, no, the same common sense explanation should extend to single women as well. What about the provision of medication abortions? Rule 4 had to be changed. And basically, the rule 4 was because the old rule was surgical 525, where you actually have performed 10, assisted 10, and performed 5, assisted 10, and observed 10. Now it was changed to create a new category of 10 medication abortions in a hospital or training center. Well, I had a bit of a disagreement here because when Foxy had a problem and we went and talked to the IMA, believe it or not, IMA actually agreed that any MBBS doctor should automatically be a provider, just as any of us MDs or MSs can automatically be providers. Then comes the medical board. Now, this is a problem. And I say it's a problem because if you have a patient, you have to make an application to a medical board. You have to present yourself. You have to justify. So to allow a deny a pregnancy beyond 24 weeks, to decide if the malformation has a substantial risk of being incompatible with life. And here they can co-opt specialists and they can call a neurologist and a nephrologist and whoever else and make the decisions. The medical board has to examine the woman and her reports and provide an opinion in Form D within 3 days. That's the important thing. The law does put the onus onto the medical board. That's the Form D for the medical board. When you're putting in an application where you give a report, you give your opinion and the investigations. Now, Yanda has said where rights to abortion and general reproductive health are restricted, those at greatest risk suffer the most. Now, what I'm going to say henceforth is going to be something that all of us as champions of women need to think about. Okay, this is food for thought. When we amended the Act and rules, we had certain lost opportunities. Between 2005 and 2010, our purpose was first to broaden the scope to improve access, to promote the availability of safe abortion. At that time, there was the National Population Policy of 2000. To support the woman's reproductive right to abortion. At the moment in India, abortion is not yet a right. To remedy all the restrictive requirements for access, to increase access to medication abortion, and to classify offenses. Now, this was a study done by the Guttmacher Institute. We are planning another one, which all of you will have to be aware about. A massive study. It covered 4,001 private and public facilities. It covered all these 6 states, and it covered 45% of India's population. And what did they find? Just listen to these findings. 48.1 million pregnancies each year, and of these, unintended pregnancies, 2/3 end in an abortion. So you have 27 million births, and according to this paper, it was 15.6 million abortions. Today, it's gone up to 18 million. 18 million abortions happen in India every year. Every time I terminate a pregnancy, I tell a woman this, and she feels, I am not alone. I'm just one of 18 million. MCI had said that this was a parliamentary question in 2018. We had 11.1 allopathic doctors, of which 8.9 are available. And this includes all allopaths, not just gynecologists and MBBS doctors, orthopedic surgeons, ophthalmologists, ENT surgeons, and all. This study told us that only 22% of abortions are happening in facilities. Abortions outside facilities are 73%, almost 11.5 million medication abortions. Many of them are done by us, but many of them are also self-managed by taking medications directly from a clinic. What bothers me here is about 500,000 abortions are still unsafe and dangerous, the ones that used to kill women in the past. So what we had suggested, which wasn't there in the Act now, and maybe we had actually suggested that the Act should define, we don't have anywhere does the Act define provide for access to safe services, medical termination of pregnancy by RMPs. The second thing, abortion is not defined in our act. It's termination of pregnancy. Now, I will tell you something that if you want to play a legal mind game, okay, when you terminate a pregnancy by a C-section, when the mother's life is not at risk, you actually get covered by the MTP Act. And can you understand that you've really terminated a pregnancy after 20 or 24 weeks? Because they say termination of pregnancy. That's why we thought, why not define it as an abortion? We had requested that at 12 weeks, please allow the woman to get an abortion on request. We have to trust women. I must be very proud of the Indian gynecologists because most of us do this anyway. But why should it be failure of contraception, mental health, whatever? Why can't a woman up to 12 weeks say, I want to terminate my pregnancy, and we do it? We had also suggested a very practical option, and this is something, Bharti, I feel we have to push. Imagine going to a medical board at 28 weeks for an anencephaly. Imagine going to a medical board at 28 weeks for a renal agenesis. It takes days. The medical board may not be sitting, though they have been asked to give it in a certain time. And doctors don't always agree on everything. So what we had suggested back then was, you notify a list of abnormalities. You decide the list of abnormalities. And if that abnormality is there, allow the doctor and the patient to go ahead. If the abnormality is not there in the list, go to a medical board. Even today, I suggest that medical board should automatically approve certain abnormalities, and people shouldn't have to go to them. And like I said, we can comfortably draw up a list of 20 abnormalities which are extremely serious and not compatible with life. Bad cardiac abnormality, a massive omphalocele, Holland porsencephaly, all kinds of such abnormalities. Okay, this is something I know that I keep bringing up, and I have felt passionately for women. And I told you earlier that 18 million abortions cannot be done by a handful of MBBS doctors. And the government, I'm not talking about private sector, the government sector has at the grassroots nurses and Ayush doctors where we are not present. If they can be trained to do medication abortions, which they were doing anyway, and you bring them under the ambit of the act and make them responsible for their actions and make them accountable for the actions. I mean, women are getting it over the counter. They are losing out on counseling. They are losing out on contraception. They will get all that. We are allowing that for skilled birth attendants. I think it's time for us to think about this as well. So maybe we need to look at the categories of nurses and the other categories. And interestingly, unfortunately, after that mishap we had in Foxy, there's a lot of evidence now, and WHO has done publications by publications where they've shown that using doctors of complementary systems of medicine, ANMs and nurses is totally practical for early abortions. And we really need to rethink what we believe in for the sake of women. So I finally end by coming back to those questions, and I'm going to give you my answers. Each one of you all will have your own answers. Should abortion be available to women on demand? Yes, I think at least at 12 weeks, why not? Why are we afraid of giving women that power? I believe women will use it very responsibly. Secondly, do you believe that the easy availability of abortion will make a woman careless about contraception? I work with women. All of you all work with women. I believe no woman ever does an abortion casually. I believe every time a woman does an abortion, she gives a lot of thought. There's a lot of thinking, a lot of humiliation. So please don't stigmatize and demean women by saying they get careless. They do it very often because they don't have good contraceptive options, because there is no male participation, because she does not have the autonomy of using what she can use. Do you believe the need for the husband to be formally involved in the decision making? According to me, it's up to her. We had this discussion in Bangalore in a Foxy meeting, and a very senior member said the husband owns half the pregnancy. And my response to it was, then let him keep his own half and let her do with her what she wants to do with her half. We are not against husbands being involved, but sometimes the woman feels the husband won't support her. The MTP Act allows her to make that decision. I was hearing the earlier presentations. She needs nobody's permission to have the termination of pregnancy. Should there be an absolute upper limit? There can't be an upper limit. See, for us, I'll tell you something very, very. Which gynecologist in India, all of us on this program who practiced in the last 30, 35 years, hasn't terminated a gross abnormality in late pregnancy? We should have never gone to court. We were inducing those pregnancies without calling them abortions. We need these because even today in our country, in spite of the spread of ultrasound, sometimes you're going to pick up abnormalities late. And I'm not saying this needs to be done. It could be done for a 12 or a 14-year-old girl who's found to be pregnant. You can't tell that go through the next 3 or 4 months because it's every day is a torture for her. And do you believe that the decision making be made by a committee of experts? I don't have a great opinion of a committee of experts when it comes to making timely decisions, when it comes to delivering just. And why should a woman and her doctor have to stand up in front of someone else and justify what is right? Nobody asks us to justify a Wertheim's hysterectomy. Nobody asks us to justify an endometriosis surgery. Why then should we have to justify this decision for an abortion? So finally, I'd like to end with this quote by Ayn Rand, who said, individual rights are not subject to a public vote. A majority has no right to vote away the rights of a minority. Just because it's a small number of women requiring late abortions, just because it's a small number of women requiring termination of an abnormal pregnancy, does not make their right any less important. It's been a privilege. Thank you very much.
Yes, thank you, sir. Dr. Harish, unmute yourself. Meera Nyotri, madam, I can see you. Dr. Rustam is there. So very senior persons are here to just hear Dr. Nojan sir yourself. So thank you very much and very good talk and really enlightened all of us. Yes, Dr. Harish, you want to say something? Dr. Alka Kurte, I can see Dr. Parag Biniwale, sir. Yes, sir.
Thank you, Dr. Nozer, for nicely covering the whole subject. And 5 questions in the beginning and same 5 questions at the end was the gist of your lecture. You rightly started with the history before the act, and you mentioned that 1971-72, when the act came, it was government of Indira Gandhi and the health minister. It was a revolutionary step, and for that I would say, we were not a backward country at that time. Very few countries were having. As on now, also some countries are not having this act. So that because current prime minister says was started then only. It is Nari Shakti Vandan. It was started then only 1972. And because you were there in a Foxy, representing the Foxy as for this MTP Act, all amendment and discussion, you nicely discussed the all intricacy. We were knowing 3-4 changes has come in 2021 amendment, but very nicely we understood by your lecture that what are the small important points and what parliamentary questions came and how you cleared those. Thank you very much, sir. Great.
Thank you, Dr. Nozer. It was a wonderful talk and very enlightening indeed. And thank you, Dr. Harish, for comparing it so well.
Thank you, sir. Dr. Parag, sir, you want to say something? Yeah.
Sure. Nozer, it's always a treat to listen to you. I must have heard you at least 15, 20 times talking on MTP, but every time I learn something new. So it is really amazing the way you address this issue, and all the thoughts are, they reach out to us very, very clearly. Thank you very much for continuing to be our patron in the ICOG, and we look forward to seeing you more and more on the ICOG platform.
Thank you. Thank you, Parag.
Yes, thank you from all of us, Dr. Shubha Gudi, Madam, Dr. Ranjana Khanna, and me as a convener of this webinar. And thank you all, Foxy and ICOG, for giving us opportunity. And thank you, Nader sir, for coming and sparing time for all of us. And really, I think we will continue to learn and learn more about safe abortion, legal and clinical aspects. Dr. Meera Neotri, Madam, you have joined. Do you want to say something? You have to unmute yourself. Yeah.
Ma'am, please unmute.
Madam, unmute.
Madam,
So
you're
like our
muted.
senior obstetricians, just like Meera madam and all Usha madam and Chandra madam and all senior obstetricians all over countries, they have trained us in the MTP and ligations, family planning services, and that lots of act, laws, situations, scenarios are changed. So we are just learning and trying to handling so that it could be better for our women health. So I think now we should just close this session.
Yeah.
So thank you very much, Harish sir and all seniors. Meera madam, you want to say something? Unmute yourself.
I don't think she's able to unmute.
हो सकता है इनको अलाउड नहीं हो रहा होगा आज तो
हाँ.
अनम्यूट ना इन्होंने उनको बनाया नहीं होगा
Hmm.
कोई नहीं है so yes we should close session I think okay.
Thanks.
So, yeah.
You are
So, good
joined
evening
today.
and thanks to again all my panelists, all speakers, all chairpersons, and all Foxy and ICOG office bearers. And finishing in time, and that is, I think, the biggest challenge. So, we have done it. Thank you. Ranjana madam, you have finished in 15 minutes. Richa has finished very shortly. Parag sir stayed from very beginning to end. Sir, thank you. And Shobha madam is traveling, but she's joined. So we all together, we are enjoying and we, yeah. अच्छा मैडम कह रही है मुझे अनम्यूट नहीं किया
Wonderful webinar, Dr. Bharti. All
They
the
really,
talks was
I was not able to unmute myself so
yeah,
far.
yeah. Now we are able to hear you.
Yeah, yeah. So I
Okay,
was
neither
actually
सबको allow कर दीजिए अनम्यूट करने के लिए कोई कुछ भी कहना
Yeah,
चाहता है
I wanted to thank all the ICOG office bearers who were here today.
correct,
And,
correct. Even I
Parag
wanted
has
to
stuck
do
on
that.
till the end,
Yes,
and Dr. Lakshmi
yes,
was
yes.
there, and
Yes,
Dr.
yes.
Uday also came. So
Correct.
it's been a very nice experience. I think we think that abortions and MTP is a very simple thing, but then when we think, but
yeah,
it's a very
and
big learning experience when once you come down to hearing about it, talking about it, and discussing it.
Yeah,
Yes,
Madam Ranjana, Madam, I wanted to say that
Yeah.
Bharti has really organized a very fantastic
Very nice.
CME
Very nice.
today. Very good. And 150 registrations and one number also did not come down till the end. I was watching the numbers
Shobha,
only, you know.
Shobha, in between, it had crossed 180.
Wow, I
Yeah.
did not see that. Yeah,
Yeah,
actually,
I
I
saw
was
it
in a
was
meeting.
189 at one point.
Excellent, excellent, Bharti. Very
Yeah,
well
It was
done.
very nice.
And thank you.
Dr.
As
Meera
you
madam,
said,
can you
yeah.
unmute? Organizer, please unmute. Make available everyone to unmute. Dr. Meera Nyoti madam want trying to say something, but
Parag,
she's not
Parag,
able to
thank you
unmute.
for being there till the end.
I
Yeah,
know,
Thank you so
Parag,
much.
you are a very
Subha,
dedicated.
you should stop driving and then talk. You know, it is we are
Dr. Rustam sir, we can see
driving
you.
and
So
talking
nice
on
to see
phone.
you. Dr.
No,
Rustam
Parag,
sir
I
is
can
also
say
here.
it is safe because it is Bangalore traffic.
Sir, you unmute yourself.
It
We
is
can
slow.
hear you. कौन है ये ICOG के सबको अनम्यूट क्यों नहीं कर रहे हैं
कर दिया
मैं कर सकती हूँ क्या को होस्ट
Kar diya, she said. Now Dr. Rustam is unmuted.
Yeah.
Good evening,
Yes, sir.
sir.
Some maybe have a few words from you.
Yeah.
No,
Sunawala sir.
it is very, very important to let the women know that abortion is available. Now, the times have changed a lot, but say maybe 15, 20 years ago, women were not aware that abortion was available. Practically, if they decide to get an abortion done, a woman will go from end of the earth to get the pregnancy terminated, taking risk about her own life. So that awareness we should make and make it as simple and straightforward as possible. Because after all, for a woman to decide to terminate a pregnancy is a very big decision. So we must support her, and we must afterwards introduce contraception so that they do not fall in the trap of coming over and over again for a termination. This is what I would just tell the fellow Obzengani people. Thank you. These webinars or meetings are really very, very well conducted.
Thank you, sir. Thank you very much.
Thank you, sir.
There
Your
was a
blessings
time
are
when
really important for us. Thank you.
Yeah. There was a
Thank
time
you.
when we were doing PG, there were so many cases of septic abortion which would come up.
Exactly. Yeah.
But now the scenario has changed. And now there's so much awareness, thanks be to Google Master. People read from there and then they know the availability.
But nowadays, Ranjana madam, nowadays the scenario is changed. For continuously last 4 days, we are getting in emergency in the midnight patients with heavily bleeding, with taking the pills by itself, and even so much of heavily bleed that they need ventilator and they need critical care services.
Correct.
So yeah, so
Because
these
if
things
she is
are
anemic,
increased very much.
Bharti, if she is anemic to bleed, begin with, and then if she takes the pills, then she's had it. Because they bleed.
No, the thing is, there has to be now, the next step is some regulation. Some regulation to bring to task these over-the-counter prescriptions which are being done
They
by
don't even tell properly.
pharmacists.
Some females have all 5 tablets together.
Very bad. Over-the-counter is very bad.
Yeah.
Something has to be done.
So finally, goodbye to everyone and thank you very much again. Dr. Rita Jha, I can see you. Dr. Alka Kurte, I can see you. But Dr. Meera Madam, I can see you, but organizer is not able to unmute you. I'm not help. I can't help. Okay.
Okay.
Some technical issue, yeah. So thank you very much and see you all in UPCOG, those who are coming. Yeah.
Yes, we'll be there.
So thank you, Parag sir. Thank you very much.
Thank you, Bharti. Very well conducted.
Bye-bye. Bye. Bye, Uma. Bye, everyone.